Okay. Okay. It is live now. Okay. मैं करता 1 मिनट चालू 1 मिनट हाँ. Vivek Bhosle, Dr. Janak Shah.
Sir, Dr. Gokani's audio is not. Sir is not audible.
Hello?
Sir, 1 minute. Sir has to unmute himself.
Yeah. Got
Huh?
it.
Now,
Hello.
here.
Okay. Huh. हाँ. ओके. मगर YouTube पे है. हाँ अभी आ गया. गोकानी सर का भी आता है. ओके.
Yeah.
So now when YouTube पे अपने को स्पीकर व्यू डाल देने का ना उसमें YouTube का स्पीकर व्यू डाल देने का ना. Okay. But we just put a speaker view that way, na? Yeah. Okay.
Credit points.
Yeah. होस्ट कर दो मेरे को फिर से. Yeah. Sir, you can try, Manan sir.
Yep. Audible.
Yeah, perfectly audible.
Good.
Yeah. Even in YouTube, I'm seeing in YouTube also.
Wonderful.
Yeah.
Hello, good.
So you give me the heads up when we want to start.
Yeah. Super bar hai. Yeah, super now. We keep this continuing now. Yeah. Okay. Thank you. If anything, I will call you. Yeah.
Sir, if the doctors don't mind, may I just try and see if the couple of slides are visible, sir?
Pardon?
May I just share the screen and see if a few of the
Already
slides
I've given permission for sharing.
Thank you so much.
You can share the screen. Yeah.
Is it all right, sir? Is it properly visible?
Yeah.
Can we see it on the YouTube?
Yeah, you can see. See, I will show you. Madam.
Madam. Yeah,
Yeah.
sir. Yeah.
See here, you can see.
Yes, I can see. Correct.
Only thing, it is slightly delayed in YouTube always.
Okay. Got it.
Okay. Yeah. Okay.
Yes.
Great.
So also, I will just try and see if the pointer is working.
Yeah.
Please.
So if I highlight the 9, is it visible on your screens also?
Yeah, absolutely visible.
Compared to the 6.8 what we target.
Yeah.
Visible, no?
Yeah.
Okay, great. So I will just escape. I will stop the share presently so that the presented screen is blank for when the audience joins.
Yeah.
Manan,
Yes, sir.
you are using Kavita's computer.
Yes, sir.
So your name is featuring as Kavita. And I'm using my son's computer, so it's coming as Arjun.
I don't know how to change it, sir. If somebody could.
No. Never mind. It doesn't matter.
Sir, it doesn't matter.
It's just that yesterday I saw you looking like a spaceman. So today I was seeing another gentleman here.
Sorry, sir. Yesterday I was in that OPD and COVID.
Yes, I know.
I'm a little paranoid. So.
Kavita's computer. So your name is featuring as Kavita. And I'm using my son's computer, so it's coming
This
as
is that delayed audio of
Yes, I know.
Yeah. Correct.
Never mind. It doesn't. It's just that yesterday I saw you looking like a spaceman. Today I was seeing.
Dr. Gokani, sir.
Yes.
Sir, that one case study which was there, should I present that case or should I skip that case also, which was there right at the end?
If you are sticking to some time, if there
Okay.
is some time frame, then see if you get time at the end, you can put it in.
Okay, and I'm skipping all the slides which are discussing the type of steroids
Yes.
and the insulin matching.
Yeah.
I'm skipping all those slides.
Yeah, yeah.
So
We will raise that in question answer.
in Q&A, we'll approach that.
Yeah.
And in very broad, as you said, very broad generic terms, so that we drive the point that
Yeah.
insulin is useful, but steroid is not mandatory, so that we don't have rampant prescription of that.
That's right. And you have latitude, don't have to stick to your slide. So this is from my little bit, 2 bits of advice is that when you start, you look at your slide and then whatever comes in your mind that is what is most important. So don't just adhere to slides and take your time, go through each slide. And if you are at the end of it, you have time, then you bring in the case.
Sure, sir, definitely. And also I'll focus more on the difficulties and challenges faced in the initiation of insulin.
Yeah, that may surface in the question answers.
Sure, sir, definitely.
Yeah.
Thank you, sir. Thank you. I'll mute myself again till I'm called.
This way.
Bolo.
We'll just start. I think now we can start because your introduction, you're welcome.
जी 500 minutes है जनक. It is 2:24 according to me.
Yeah.
So since it is at 2:30, I think let's wait. How many people have joined?
In YouTube, it's showing 16%. 16 આપડા પણ હજી લોકો નથી આવ્યા.
હા એ તો કહું છું આપડા બધા બાપુ છે.
Really great, yeah. In spite of telling everyone.
એ ગમે તે ના કહો તમે. બધા અત્યારે બધા લોકડાઉન માં સુઈ જવાની આદત પડી ગઈ છે બધા.
સુઈ જવાની.
તમે એમાં જો ને આપણા YouTube માં જો કેટલા છે સાહેબ. અહીંયા Zoom માં 14 people are there.
હા 21 there અહીંયા આગળ.
YouTube માં કેટલા છે?
21.
ને અહીંયા 14 છે.
Sir, અહીંયા તો only the people who are addressing. Yes, only
the managing committee also have invited. So
Zoom in the Zoom.
Yeah.
So I can see 2 people, Ashwini Patil and Mustafa Badami.
They are the guest.
Acha, okay.
Yeah.
No, sir. I'm regional medical advisor from Sanofi.
Oh, great.
Yeah. Wow, Nalini madam has joined us.
What about Dr. Mehta?
Huh?
Mehta has come?
Manan has come.
Yeah. Dr. Manan
He has
Mehta
already come.
Because I can't see his name here.
Dr. MV Mehta is written.
MV Mehta is there, yes.
Yeah. Anita.
And Dr.
Sir, change કરી નાખો તરત જ.
Join our meeting.
Gokani sir?
Yes.
Sir has changed immediately.
Yeah.
Either he has changed the computer or he has changed the name.
On all of them, and please join.
No, this is my son's computer.
No. Manan sir.
Oh yeah,
Manan
he
sir.
changed. I think he changed the name.
Yeah.
You can make us a co-host,
MB Mehta.
then I'll
MB
do it
Mehta.
from this
Yeah.
side.
આવી ગયા Mehta સાહેબ પણ આવી ગયા.
Yeah.
What about Jinam Shah? Hi, Preeti.
જીનમ ના થોડો મોડો આવશે. PPE kit માં હશે.
My God, don't tell me.
બરાબર ને?
Yeah.
सुरेश अग्रवाल आ गया. Good.
Only thing, one thing we do is when speaker is on, when someone is talking, let us, I will be putting everyone on mute.
Yeah, yeah.
Vibhakar has come. I just saw Vibhakar.
Yeah, Vibhakar is.
Vibhakar, welcome.
जनक, हाइपरटेंशन का स्लाइड्स आप शेयर करेंगे ना?
मैं कौन सा आपका क्वेश्चंस का?
हाँ.
ओके, आपने भेजा मेरे को
या ईमेल किया आपको. हेलो सर.
ओके.
डॉक्टर अदोरैया.
या हेलो
विभाकर આ બીજો ઊંઘવા વાળો આવ્યો.
जनक आप टेस्ट देखो.
I'm doing it.
Yeah.
Just give me 2 minutes.
Yeah. Take your time.
Hey. कौन पढ़े?
Vinayak has come.
Vinayak Shinde has joined.
करता हूँ.
जनक, you'll do it. आप किसको बोल रहे हैं?
चालू करें. काय झालं? सूर्यने कापलेली.
या डूइंग इट. आपको ही बोल रहा हूँ.
अच्छा.
चालू है काम.
ओके.
हलवलं ते.
But Sunita madam, you have the question with you now, for all the panel people. With you also it is there now.
Yeah, with me also it is there.
हाँ, तो फिर प्रॉब्लम क्या है यार? अगर वहाँ से
स्क्रीन स्लाइड पर आना चाहिए ना, स्क्रीन पर for the audience.
That Janak will handle, no?
हाँ, yeah, that Janak will handle. Yeah.
पूछ लो आप जनक से, कंफर्म कर लो.
एज करू है ने.
हाँ, बस ठीक है. बस very good.
Now you can see.
But I can't see the screen.
नहीं, अभी आपने शेयर किया, स्लाइड शेयर किया आपने?
नहीं कर रहा हूँ.
What about Dr. मेहता का स्लाइड सब डाल दिए?
हाँ, ये तो આવી ગયું.
हाँ, ओके. અને ઓલા જીનમ શાના પણ
એ તો मैं તમને કહું ને, તો હજી આવે ત્યારે નાખે ને.
એ અચ્છા ઠીક છે.
ના નથી હજી બીજા નહીં હતું.
Good afternoon, sir. So on the original link which was given yesterday, I have posted it, but also post the present link on the yesterday's link so that those who go to that page by mistake can come to the.
Already, you want the link?
I have it. Just we'll post it on the yesterday's page also, because a lot of doctors have gone on that link, sir.
Oh, yeah.
કાલના લિંક પર નથી આવતું.
હેલો.
ભરતભાઈ, you can start now.
બસ મને આ કે એટલે I am ready.
Because 2:32 થઈ ગયા સાહેબ, પછી ટાઈમ નહીં મળશે આપણને.
એજ મેં કહું, ચલો.
જનકને બોલો, we'll start here.
Yeah.
હા, come on, ભરતભાઈ.
Can I start, જનક?
Yeah, you can start.
તો કહી દો આ બધા, તમે ચાલુ કરી દો.
એક મિનિટ સાહેબ, એક મિનિટ. હા,
વાજા આવ્યા કે નહીં આપણા સેક્રેટરી?
નહીં, હજી નથી આવ્યો.
Stop share contents. So, how do I share?
Main screen किधर है? तू उधर अंदर से फोन से कर. Madam, I'm not able to do your this thing, huh?
अरे डॉक्टर साहब, हाँ बोलिए.
थोड़ा टाइम लगेगा मेरे ख्याल से थोड़ा. I'm not able
नहीं,
to
डॉक्टर
share.
मेहता का तो स्लाइड है ना आपके पास?
Yes, got his.
हाँ, तो फिर वो तुम लगा दीजिए बाद में. अपना तो क्या
नहीं,
4
वो
बजे
उनका
का टाइम है.
वो that is he will share. No, that is no problem. I'm just planning. Means मैडम का ये जो है ना.
हाँ.
On panel discussion one. Let's see whether it comes. आया क्या उस पे?
नहीं आया.
Okay, we'll stop share.
આવી ગયું તમારી પાસે. Very good.
Panel discussion આવી ગયું.
આવી ગયું ને?
આવી ગયું સાહેબ.
તો કઈ વાંધો નથી. દેખા હે તો હું થઈ ગયો.
મેહતા સાહેબ ઇઝ લાઈક ટુ ગો સાહેબ.
અર્જુન કોકાની આના સસરા.
કોણ?
નાનીના.
પૂનમ શાહ સાહેબ પણ આવી ગયા. ચલો ગુડ.
હેલો સર. સસરા.
ગુડ આફ્ટરનૂન.
I think ભરત ભાઈ.
કોણ પેલા છે?
You have to wait for the secretary.
અર્જુન કોકાણી એના સસરા.
ક્યાં છે? એને ફોન કરશે કોઈ?
મારે હું જ કરું.
અર્જુન ગોકાની મારો દીકરો.
અરે આ હું અમારું કર્સર જોઈને મારું એરો આ કર્સર પર જો આ તો જનક છે. આ અર્જુન ગોકાણી.
Janak, what we are going to do now?
Can start now.
नहीं अपना
हो जाएगा आपका शेयरिंग.
हो गया
है ना आपका शेयरिंग.
हाँ तो वाजा ने राह નથી જોવી ને. વાજા ને ફોન કર્યો કે નહીં? Okay. Now, good afternoon everybody. You know, I welcome you all for the first of its kind webinar by GPA. As you know, because of the current lockdown, we could not continue with our routine monthly CME. So this is our first attempt. So a little bit snagged over and there, please bear with us. And we have about 2 speakers, and the third will be our own GPA panelists who will be discussing mind-churning questions on hypertension. And we know that we all have to face and change the lifestyle modification. And I think in current lockdown, I think Mahmood will agree with me that instead of lifestyle modification, it has become lifestyle modification. Anyway, I invite Dr. Anand Gokani to introduce our first speaker, Dr. Anand Gokani, who is a consulting specialized physician in diabetes and metabolic and lifestyle related diseases since 1986. He is attached to Bombay Hospital and Medical Research Center since 1988. He is also a consultant attached to Castrol India, where he looks after the employees and their families. And he has been in active practice for the past 34 years. So may I now invite Dr. Anand Gokani to introduce our first speaker, Dr. Manan Mehta.
Thank you very much, Bharat Bhai. Uh, it's it's a very unique experience to be part of a Zoom meeting. As far as I'm concerned, every time we had a CME, it used to cross my mind that CME means not continuing medical education, but come meet and eat. And we'd come meet and eat all the time and chit chat. But the problem is that on a Zoom meeting, there is no come, no meet, and no eat. Only talk, only enjoy academic snacks. So what we're going to have today is not from a gray-haired old fogey, but from a black-haired young stalwart who is going to be the speaker of the day, that is Dr. Manan V. Mehta, who is a specialist in metabolic syndrome and is a consultant practicing since the last 8 years. After his undergraduation from Terna Medical College and Sir J.J. Group of Hospitals, he pursued diplomas and certificates related to diabetes and thyroid disorders, after which he has had several centers from where he works to treat diseases pertaining to thyroid and diabetes. He has a consulting room at Marine Drive and is in charge of diabetes and thyroid at multiple charitable centers in South Mumbai, Ghatkopar and Jogeshwari. He has a special interest in diabetic kidney disease, LADA, and other forms of insulin-dependent diabetes and geriatrics. He is multilingual and a self-confessed, not alcoholic, workaholic. So, and you can see from his demeanor that he's a fitness enthusiast. And he says that he reads a lot. I read a lot too. And I love listening to someone who reads a lot. So without coming in between you and Manan, I invite Manan. Manan, all the very best. Smash the audience. Go ahead.
Hello, good afternoon. Thank you. Thank you so much, sir, for the kind introduction. And a word here or a word there could have made a lot of difference. So I am without wasting my esteemed audience's time, we are running a little behind. So we'll get right into it. I am first of all overwhelmed by the sheer panel which is in front of me and the large number of doctors who've joined us on a nice lazy Saturday afternoon. As sir said that, skipping the food and skipping the prandium and in the post-prandium phase to join us and talk about insulin is a challenge in itself. So I will not take a lot of your time. I will try to highlight the basics. I will try to address the major issues which we are facing as far as insulinization of our patients is concerned. And I would like to start with my concluding slide because of the sheer experience in front of me. All my bosses, all my masters are here. So I won't be condescending enough or arrogant enough to assume that I know even 1% more than you. So just spare your attention to me for the next 5 or 6 minutes while we go through what I am trying to put across today. And then feel free to check your messages and let your attention wander till Jinam sir comes and wows us with an interventional pulmonology section of the talk today. So a very basic in a nutshell is that despite COVID, what we have seen is human beings are here to stay. We are here to stay no matter what disease, what epidemic, what pandemic comes. Secondly, if human beings are here to stay, diabetes is here to stay. Third, if diabetes is here to stay, then insulin is also here to stay. So if you are going to be managing this field, knowing how to use insulin, when to use insulin is something which you are already well versed with. But when to not fear that insulin, so that if I am not afraid of using the drug, that is when I will be able to make my patient unafraid of using that drug. That is the major issue. We face many, many difficulties. We'll come to that in the middle of the talk. I compare the difficulties in starting insulin with the Kubler-Ross model of accepting the loss of a loved one. The stages of grief and the stages of adding insulin in an Indian setup is absolutely the same. Finally, all insulins can be used. No matter what is the agenda, no matter what is the idea, all insulins can be creatively used. Starting from the very basic basal insulin to your advanced insulins to the ultra rapid acting analogs or using your plain rapid acting human insulin also. The creativity on how to use it, the number of pricks involved, and the quality of life which we leave behind is what determines the choice and the dosage. Many a times we get a lot of questions regarding, is insulin a must in all infections? Yes, this is something which I would humbly like to put across, that insulin by itself is a fantastic tool for the body to fight inflammation. So if there is any inflammatory or infective condition, the demand for insulin definitely goes up. The medications involved, the situations involved can also result in a spike in the insulin resistance involved. Hence, using insulin in acute indications is an absolute must, and I'll throw some light on that. So that's it. That's my talk today, and that's all I would like to share with you. But if you're still interested, let us look at each of these things in detail. Every point which I said, I'll be putting up some data to back it up. But please don't believe me. Please don't believe the data. You can always cross-check, because all numbers can be manipulated. I think everybody practicing in the COVID age now knows that all numbers can be manipulated into making you believe what you want to believe. So definitely diabetes is increasing. It has an expenditure of blah, blah, blah. But this first line is something which I don't agree with, is where they said that the total global healthcare expenditure due to diabetes is so and so. I believe that diabetes is like a bad investment which you started making today in a company which will crash 10 years from now. All your savings which you will keep putting for 10 years will not only collapse, but it will also eat away into the interest which you could have earned otherwise. So managing your patients and spending enough time, money, and energy in maintaining a diabetes today is in fact an investment which you make for 10 years down the line. Because if somebody tells me that this molecule costs 20 rupees a day, it comes up to 600 rupees a month. This is a cost which we cannot bear. However, the cost of an investigation, just like an EMG or a retinal screening or any complication which needs to be screened, can be far more than whatever is the cost of insulin or any OHA which you introduce. Explaining the long-term picture, just like how the bankers call us up and dupe us into investing in all these SIPs and funds, we have to explain to the patient that the limited amount of time, money, and energy which you put in managing your diabetes today helps you tomorrow. This is something which we are very well aware of. I think this is a question I'd like to post. All the doctors in the comment section, please feel free to honestly put across what you think is the average HbA1c in your routine garden variety type 2 diabetic in your clinical practice. I know that on a platform, on an official platform, we will all want to say, we like to target between 6 and 7, 6.5 and 7. But genuinely, in my practice, at least I see that between 7.8 and 8.2 is what the average HbA1c is. So definitely I am lagging behind in bringing that average HbA1c down. Please feel free to put it in the comment section. What is the average HbA1c that you are also facing in your day-to-day practice? So despite of a large number of patients not being adequately controlled, what do? I believe we do what is the buffet pattern. We go to eat in a wedding. We're not happy with what we can eat. We want a buffet. The same way, we lay out a buffet of OHAs first. Each and every one will be tried. Sometimes patients come to me with 4, even 5 OHAs by the time they're referred to me. So when we look at this graph, it's a very nice graph. Just look at the India, ignore the Mexico and Saudi Arabia for the time being. The India graph, the green, is the number of patients who are treated by oral drugs alone. And the blue represents the number of patients treated by oral drugs and insulin. Now let me take you back to the previous graph. If we have about 45% of our population above the HbA1c of 8 and about 37 of them between 7 and 8, don't you think that the number of patients who are on insulin in our population should be higher? So when you compare the two numbers, all that these two graphs show us is that nearly 50% of the patients who deserve insulin, who are rightful candidates for insulin, are not receiving the same. So why is that inadequacy there? The inadequacy of OADs, we won't get into that today. There are multiple theories which are going on. Beta cell exhaustion, beta cell dedifferentiation, pancreatic spasm. These are various theories which are going on. But in general, to put it in a simple nutshell, is we've got significant insulin resistance. or significant insulopenia. Both of these situations at the extreme spectrums of the clinical picture both present to us accordingly. In fact, there are many patients who come with catabolic features and still they are put on OHAs. Definitely the sugars will come under control within a month or two. But I think it's high time we realize that we are no longer treating blood sugar. We are all specialist physicians. We are all looking into diabetes. So we are no longer interested with just the number which comes when we check a random blood sugar. We are in fact interested in the glucochronology of the sugar. We are looking at the cardiovascular safety for each and every diabetic drug. I mean, we don't check whether a cardiac drug has any effect on the diabetes, do we? We don't check if a cardiac drug has an effect on thyroid. Amiodarone is still frequently used. But every diabetic drug which we use, we look into the CV safety. Why? Because we are not just responsible for getting that fasting between 90 and 130 and the PP between 120 and 160. We are also responsible for not only bringing that sugar down, but making sure we are averting the micro and macrovascular complications. So if we initiate insulin early, let me just divide it into two broad things. If I initiate insulin early, is it actually useful? Number one. Number two, if I initiate that insulin early, how low should I go? How low is too low? And if I am going too low, if I'm say offering an intensive control, is it actually benefiting my patients? So the UK-PDS gave us this beautiful study, whose data, the UK-PDS, Advance, Accord, Origin, these are landmark trials whose data we'll go on exploring and we'll go on seeing in detail for years to come. Most of the patients at the time of initiation of medication had about a 50% efficiency of their pancreas. This was measured through the HOMA, beta, IR, etc. mechanisms. So definitely we were adding insulin late. What are the indications for insulin? When somebody asks me that what is too late, what is too early, I will say very simply a non-catabolic, please mark my words, a non-catabolic type 2 diabetic, not controlled with your current OADs, you're given maximal, etc. Or those who need a flexible therapy, which you can't just give them a full-blown drug. They have a lot of intolerance to OHAs, other complicating factors are there, then they definitely deserve insulin. The HbA1c targets keep changing, but if your patient is already on a triple drug combination, I had a word with sir, he's given me the freedom to comment a little beyond the specific guidelines also. So let us be honest, about 70% of our patients will be on 4 OHAs and not 3. So even on that, if the patient is not under control, HbA1c is still pushing 8, 8.5, your patient deserves to drop a couple of OHAs and add a simple insulin. Of course, if there is ongoing catabolism, just controlling sugar won't help. You will have to overcome the insulin resistance and give them some insulin. Obviously, if the HbA1c at presentation is very high, if the HbA1c is more than 10, etc., then you have no choice. Also, certain specific conditions are there. Your acute macrovascular emergencies like an MI, stroke, etc. Those who have an impending surgery, any acute complications, DKA, your any kind of acidosis which is there, whether ketotic, non-ketotic, doesn't matter. Definitely in pregnancy, we have a subset. Patient, known case of diabetes, already on metformin, might choose to continue. But a newly diagnosed diabetic, if there is a GDM, please shift them to insulin, works very well on them. Of course, if a glucocorticoid therapy has to be introduced, then understand that glucocorticoid therapy works in multiple mechanisms. It's not just about the rising sugars or increasing your OHAs. It's actually about overcoming the insulin resistance also. So small insulin sensitizer with a good dose of insulin takes care of it beautifully. So I think these indications are known to all of us, and there is nothing new about this. So coming to my initial question, that does early initiation of insulin actually help? This was the question that was looked into by Hanfield et al. And Owens et al. These two studies were combined. And what they found was that early initiation of insulin, not waiting for the so-called treatment failure, does help our patients. So what we did was, Holman et al. Just divided the patients into two categories. One of them received a conventional therapy where we were sort of treating to failure. metformin 500, then 1 gram, 2 gram, not working, add something, not working, add something, etc. And the intensive arm, what we tried to do was, we initiated the insulin early and tried to keep them a little lower. The whole point was, this was a long study, this wasn't a small study. When they saw these patients at the end of 6 years, 9 years, 10 years also, the patients who were on the intensive arm tended to have a better HbA1c. So you're making an investment for a long term. That is why early initiation of insulin might help. Another thing what happens is you are dragging the baseline down. So when you look at this graph, I know this graph represents our treatment to failure pattern, where we first try with LSM, then we give a monotherapy, then up titration, 2 drugs, 3 drugs, 4 drugs, not working, then basal bolus, blah, blah, blah. This graph very beautifully, if I remove the numbers altogether, I'm sure this represents the eating pattern of an average Indian also. We are like a cow or a goat who needs to munch throughout the day. There are multiple meals which will go on happening. So in general, to drag that average HbA1c down, to create that sense of fullness, to prevent multiple feedings to happen, you have to initiate insulin. Now, this was also in terms of metabolic control. So what did Wright et al.? It's a very old study actually. So they were looking at metabolic control not in terms of just your conventional approach and insulin alone. They also looked at it in terms of adding sulfonylurea to insulin. Even that seemed to work, but had significant weight gain in that study, if I remember right. Now, if we give early and aggressive insulin, does it help to be aggressive? Now we'll move from the early part to the aggressive part. Does it actually help? Yes. Again, the same Holman et al. Study said anything towards the right side favors conventional therapy, anything towards the left favors intensive. So all-cause mortality, MI and microvascular complications, all were in favor of intensive therapy, but a signal for stroke was found to favor conventional therapy. Mind you, this was a study back in 2008 when the details were released. This was studied in detail further, and I'll come to that in some time. So the current strategy, which is there, that if you give insulin at the right time, you can prevent a lot of complications from moving ahead. You don't need to wait that lapse period, which is there. Already the patient is coming to you a few years too late. Waiting further creates more complications. So initiation of insulin, this study, when Kunti et al. Had done this study, this was years ago when I first saw it. How many patients, what that number represents is that the probability of a patient coming with an uncontrolled HbA1c actually receiving the insulin. So only 1/5 to 1/3 of the patients who actually deserved insulin were getting that insulin. So now we looked at it in a different manner altogether in the Origin trial. Bear with me, I don't like discussing trials in detail, but this was a beautiful one. It was a 6-year randomized trial where we didn't take, so you remember we had that signal with the stroke in the 2002 data, 2008 data, we had that stroke is something which favors conventional. So what they did was they got hold of people only with a high CV risk. So this cohort actually was not your garden variety T2DM walking into your clinic and say, Dr. Saab, sugar aaya hai in my multiple 2,000 rupee package deal. They caught hold of patients with a high CV risk only, and they either had impaired fasting glucose or impaired glucose tolerance or an early type 2 diabetes with no treatment or 1 OHA. They divided them into 2 categories, those receiving standard glycemic care and those receiving insulin glargine to a very intensive control. So they studied that for 3 major things. Number 1, there was a neutral effect on CV outcome. Controlling your patient's sugar well does not have a negative CV outcome. There was no spike of cancer. Glargine was associated with a small signal was there initially, hence this fear was there, but there was no link with cancer. And finally, it also helped prevent progression to an over diabetes. That was the beauty, that was the fantastic thing put across, that catch hold of your patient early, start soon, start aggressive, take care of them, it will help you. Now, why is the low insulin rate? Let me come to the meat of my topic today, that the insulin distress, there's apprehension, there's discomfort, blah, blah, blah. It's there. I think it's like stages of grief. When I first tell my patient, you need insulin. Huh? Me? What nonsense. My neighbor has diabetes for 33 years and her sugar has always been 300, even though she's had 2-3 MIs. She's never needed insulin. Why should I need insulin? Then they get angry. This doctor, no, I am telling you, 5 other patients had gone to him. He has put everybody on insulin. That is his problem. They get angry. Why me? Why am I getting this insulin when I don't? I will do this, I will do that. That I will do this, that they bargain with you. Doctor, actually what happened last 3 months, this festival was there. My daughter's wedding was there. My building was under construction. I didn't have running shoes, blah, 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 blah. And then comes the depression that, you know what? I have tried a lot of things. Nothing is working out. I'm seeing these people who are uncontrolled diabetics. Maybe I do need insulin. And at this stage, they will not have acceptance for taking insulin. They will go doctor shopping. They will call up Bhatt sir. They will call up Merchant sir. They will call up Gokani sir. Kuch aur rasta dikhao. Kuch aur rasta dikhao. And everybody will finally tell him, boss, you have come. You need insulin now. And that is when finally an Indian patient will be agreeing to take insulin. So what do you need to do is we need to, how we prescribe, say for example, if we prescribe aspirin or an NSAID, or now recently if we prescribe favipiravir to any patient, we explain that expect gastric side effects. Somebody whom I prescribe, say a weekly GLP-1 like dulaglutide, I tell them some nausea, some acidity is going to be there. So when we talk to them about the possible side effects, they feel a little reassured. So the weight gain is the biggest fear they have. Next, permanent. For everything, if I start the medication today, I will have to take it forever. It is a common sentence which we've always heard. Tell them this way, that if your loan is 50,000 today, if you start repaying it today, there is a chance you'll be able to repay it. But if you start with 100 crore loan, there are chances if you waited for so long, you will not be able to repay it. So the later you go, the longer the therapy might last. Then there is a fear of hypoglycemia, that I'll take insulin, my God, my sugar will go low. That fear is in fact there in a lot of doctors also. If the panelists don't mind, I will share a personal experience about the same. Years ago, when I was posted in Gandhinagar, at that time we had the swine flu epidemic, and Apollo Hospital in Gandhinagar was in fact one of the designated centers for all of northern Gujarat, southern Rajasthan, and western MP. And we were all afraid. We wanted to limit the number of visits we did for our COVID patients in the wards, for our, swine flu, everybody's COVID right now, my bad, for our swine flu patients. And we were afraid to use insulin. We were afraid to administer insulin. So we were told that here is the pen, take it on your hand and to put it, take it on your thigh, put it, or take it on your stomach and put it. Use it on yourself, inject 2 to 4 units and see how uncomfortable you are. We did that. We realized that this micro needle is beautiful. It is painless. It works wonderfully. That's why I stopped using the word injection. I tell all my patients separate insulin and injection. That helped me a lot. We went on the rounds. We finished the rounds and we came back and the doctor said that, are you all hypo? I said, no, we are not hypo. But because we took a placebo, he said, no, actually you all have taken 2 units of insulin. So 2 units of insulin did not make us hypo, but that was actually a placebo, but telling us that removed the fear of insulin which we had, and hence we could prescribe to the patient. Now, the feeling of failure which is there, that have I failed? Because we all love to use insulin as punishment. Ye karna, agar ye karke nahi aaya, next time HbA1c itna nahi laya, तर मग मी बघ तुला insulin देणारच आणि तुला घ्यावाच लागेल, म्हणून मी सांगतो असं बंद कर, तसं बंद कर. We need to stop using insulin as a punishment, and we need to start believing that it's a flexible thing. Most important question is also that, is it going to be expensive? No, it's not going to be expensive. As I explained, in the long term, the amount of complications it helps you avoid, it is actually a very, very easy way to do. It's a good tool. You have to explain that the more you exercise, a decent amount of exercise in all of our patients, almost all of our patients who are not requiring more than 60 units a day, and those who don't have concomitant pioglitazone insulin, sulfonylurea insulin prescription, they don't get that much of weight gain, which is, the fear which they carry around. So there are certain barriers in language. How do we explain? When I was in Christian Medical College, Vellore, when I was there, very difficult for me to counsel, and I rely on counseling my patient, sitting them down, talking with them for a few hours. I make them see a few patients taking insulin in the clinic. That's when they feel a little confident. These concerns are there, but now these concerns are being bypassed beautifully by these big giants. They have this fantastic tool also. At the end of it, if possible, we could just mention the name of that tool, which you can just put your patient on that. They are called, they are explained how to use it in their language. All their questions are addressed. It becomes very easy for them to initiate, up titrate, down titrate. It's a fantastic tool. Now, most important thing that we need to do is, after alleviating the concerns, you demonstrate, you've explained everything, now what? Now the most important part what you need to do is, you need to help the patient personalize. They have to personalize their insulin. They can't come to your clinic every day, especially in the present circumstances. You can't meet them every day. You can't guide them in terms of how many units to increase, decrease, so that they don't get insulin distress. I know a lot of patients who take insulin and tell me, doc, I've been taking insulin for 2 days. Sugar is still that much. How did this insulin help? Doc, I took insulin 1 dose yesterday. I'm feeling like shivering. My knees are weak. I'm getting palpitations. I'm feeling heavy in my chest. I'm not able to breathe. What has happened? And I tell them it's a panic attack. It's not hypoglycemia because the sugar is still 220. So that titration of insulin becomes the biggest factor which we need to look into. And for the titration, I like to start with a basal insulin, because a basal insulin is one of the easiest to titrate. So now just the last part of my presentation, why basal insulin? Because basal insulin is found to definitely be effective, more effective than your premixed alone. There are multiple studies, which say this. Ramchandran et al. Had a poster presentation in Busan, all the way in Busan last year, where they presented this data, where they said that those achieving less than 7% HbA1c were a higher number in the basal insulin alone. Then this was the data. Then we had a real world study. So in the real world study, in the Fine Asia part also, we found that baseline insulin is definitely working with the least amount of hypoglycemia, the main concern which you have. Now, premix has its own advantages and disadvantages, and so does basal. Today, since I'm speaking about basal, what makes it easy for me for the basal is, most importantly, is the compliance part. The compliance part becomes easy for me, and that allows me to actually manage them better. There is a lot lower rate of hypoglycemia, and believe me, if we start early, the prandial part can be taken care of easily otherwise also, since you brought the whole average down. As far as 50-50, 30-70, 25-75, the mix which are available, they are beautiful. They can definitely be used. I'm not an advocate for one or the other. I always say depending on the patient requirement. But in the initiation of a patient, I always say what I was taught by my masters: basalize the patient first and then prandialize them. And I think if Dr. Gokani would, at the end of the talk, just tell me if I'm right about this or not. But this is what we try to do in the newly diagnosed patients. When we just had human actrapid to work with, we used to first put them on a basalization, put them with the fluid, keep a check on the potassium, make sure that they basalize first, and then we prandialize them with the subcutaneous bolus doses. That what it did was that there was lesser variability. There was a more predictable action of the insulin. The requirement of insulin was lesser because we've finally got the average down, and the titration which was there became easier. So the points which are mentioned here are the challenges which were there with the premix or the co-formulations, and this was there. I am fairly young, but I'm working since so many years. There was still a good period of time where premix was not available. We used to mix the insulins together, and that mixing itself, दुधेरी एवढं घ्यायचं, ते clean आहे ते एवढं घ्यायचं, दोघांना असं mix करायचं. There was a lot of problems with that also. Sometimes they would take more, they would take less, they would have to throw it out. Now the prefixed are available, which does make it easier. Finally, it's common sense, something which creates lesser variability, creates lesser prandium, creates lesser goat, mentality of I have taken insulin, so I must keep chewing on something all day long. So it resulted in lesser weight gain and definitely a total lesser dose also. I'm just saying these things, but at any point of time, there are studies which back it. If there's anything in detail required, please feel free to share with me at the end of the talk. I'll speak about that particular study in detail. So how to use basal insulin? Nothing. Learn to convince yourself and your patient. Call this helpline number, tell them I have prescribed the insulin, now you take care of the headache. Because a couple of weeks back, I had this experience where I put a patient on insulin. I didn't get a call. I said, "Haan, chalo, chhod diya hoga." And a week later, the patient calls me, "Doc, my sugars are in control." And I said, "How did this happen? How did I not have to counsel my patients 30, 40 times to use the insulin?" It turns out they got onto the helpline, they got onto the Sat, and they got beautiful tele support. Long story short, it helps save your time and mine. So Be Smart consensus was the 70s treatment initiation, the timing, transportation, how to keep it in the refrigeration, whether I can keep it outside or not. If I'm traveling, what do I do? I work at office all day. I don't have a refrigerator. I think all of you all know these things. I don't need to get into too much detail for that. And starting dose now, how do you start? What is the right initiating dose? 0.2 units to 0.3 units per kg is what all the textbooks say. Sometimes, to be honest, now this is my personal recommendation. This is not a guideline. In my Indian patients, my masters can correct me if I'm wrong. In my Indian patients, rather than 0.2 to 0.3, depending on the status of the patient, depending on the weight of the patient, I sometimes even go as low as 0.1 to 0.2, between that units per kg to start. And sometimes I just start with a 10 unit fixed dose for a 60 kg average patient, depending on the level of insulin resistance and the average control they come with. And sometimes a 12 or a 14 for a heavier patient, obviously a little more. And then what I do is I titrate it according to the fasting sugar. Many sliding scales are available, but teaching the patient to do this is absolutely crucial. If there is hypoglycemia occurring, find out why is it occurring. Make sure we check the 2 a.m. sugar. Please don't ask me which one is Dawn, which one is Somogi. I always confuse the two, but I do know what to do if the 2 a.m. is high or low, depending on a high fasting which is there. So make sure at least twice in the first week, the 2 a.m. sugar is done. Even in the nursing homes, wherever the patients are admitted under me, I request staff that please bear with me at 2 o'clock. You call me so that you don't feel bad about being up at night at 2. There is someone with you who is up so that we can adjust the dose for the morning if need be. So this is fairly simple. This is not didactic. This is a suggestion. This is not a recommendation. You have to
Sir, 5 minutes
to your patient. And what we do is in these 2 slides, we look overall at what we need to do. You need to look at lifestyle modification as the most important factor. Right insulin technique, they're holding it wrongly. Are they holding it there? Is that last drop escaping unnecessarily?
Sir, 5 minutes more.
Sure, I'm done, sir. I'm done. Thank you. Okay. Squirting it out, is it going out? Is it being wasted? We have to look into that. And ensuring when to give. Some patients of mine, my elderly patients, my advanced CKD patients, my fragile patients, patients who like to fast at night, whether they are Jain, whether there is fasting going on, you have to decide whether to give a morning dose or an HS. You should educate them about their target fasting. Somebody who's been on 300 all their lives, please check their potassium, please check their ketone status, please check their catabolic status before giving dhadam, a big dose of insulin to bring it down to 100. Starting dose can be low, but it can go up to 0.5 units per kg also, depending on the urgency of the situation and the metabolic stability of the patient. And you must titrate till you reach the fasting. You have to help them with that. You have to be accessible. We all go through about 100 to 150 phone calls a day, but we have to do this. We'll leave the case aside, and I will just put it towards I'll put it on the screen, what I believe, what is there. Presently, I don't care what the media says. I don't care what the politicians say. I don't care what anybody says. We are all here in it together. Let us help each other, stand with each other. We have all worked hard. Those hall room people, those who are shouting on the television sets, trying to distract the issues. We are all stressed. We are all distressed at the number of sheer hassles we faced in fighting the disease. We are fighting bureaucracy and complications apart from disease, but we are proud. We've done our best we can. Finally, some very well educated person, a very senior gentleman, said that even a ward boy or a mama or a compounder knows more than us. I think that is not an insult, but it was said it in an insulting manner. But I think it's a positive, because I was taught suturing by my mama. I was taught how to put an IV line by my staff. And till today, I don't go and do the blood collections for my COVID positive patients at home. The paramedics do. So they are with us. All we are a team. And I thank you very, very much for a patient listening today afternoon. And my humble request is that let us stay united. And the GP has done a great job of bringing hundreds of doctors today in this effort. Thank you so much. I apologize for any mistakes which I've made in advance. And I'm sure my masters will correct me if I've erred somewhere. Thank you. Thank you so much.
No mistakes, Manan. Superb speech from beginning to end, A to Z. So there isn't much you left for me to speak on. You covered every aspect of it, and really proud that you've done it so beautifully. I just like to say one or two things. One is that when we decide the dose of insulin, there was a chart which said that if you have a weight of this much, then you give this much insulin, and if you have a weight of that, we should have an introduction into that slide of the word ideal body weight, because sometimes you have a person who is grossly overweight, who may be 80, 88 kgs, but his ideal body weight would be 65. Then we should calculate insulin according to the 65 weight, or else we'll just be pandering to his cravings, because you'll start him on a insulin which may be so high that he just wants to keep eating to fund that insulin. And then the weight would keep increasing. So I think we need to just add that word ideal body weight, wherein we don't just take the scale and we take the weight which is supposed to be and calculate according to that. And the other thing, you asked a very valid question as to how many people who have ideal glycosylated hemoglobin or HbA1c in their normal practice. And I remember attending an ADA meeting many years ago at San Diego, where one of the very eloquent speakers kept on harping on it, that it should be less than 7, less than 7. And he said it so many times that at the end, out of irritation, I got up to ask a question. And I said, sir, you're a clinician also. How much is the HbA1c average of all your patients? And he very sheepishly replied that is between 8 and 9. I said, it's very good for a scientist sitting in a laboratory to decide that 7 is the ideal number, knowing full well that no human being can achieve 7 and less if he is a diabetic. If he is not a diabetic, nature takes care of him. But if he is a diabetic, you have to give him a target that is realistic. And I think what you said about your patients being between 7.8 to 8.2, I think you're doing a remarkable job, because most people's average is maybe 8 to 9. My average, I can't say average, I have a very lopsided numbers. Some of them are as high as 14 and 15 when they present for the first time, but average lies between 7 and 8. And I'm happy with 7 and 8, even if ADA and EASD scream from the top of the hills and say that we should have a HbA1c less than 7, which is something theoretical. Theoretical doesn't have to go into practice. So these are the two important additions I'd like to make. Otherwise, Manan, superb speech, superb explanation, simple language. I think all of us, despite all our aging gray cells, have grasped many things. So if there are questions from the audience, it would be lovely to take them up. If anyone wants to make a comment, please take it up at this moment. We have one very important thing is you mentioned somewhere in passing about steroids and diabetes. And I can say that, and I'm sure you're experiencing same thing, as that many patients with COVID are coming into the hospital, coming to hospitals in a semi-complicated state. And in such situations, it has been advocated also largely by medical literature that additional steroids may be beneficial. Now, assuming that such a person is put on steroids, then it's quite possible that his glycemic control may go haywire, and as a result, he may have complications due to some other reason and not COVID. And diabetes may complicate his COVID complications. So, Manan, you'd like to elaborate on that point of how a COVID patient receiving steroids should be given, how to treat him?
Sure, sir. I'll just take a minute to highlight that. Again, I feel very sheepish talking about COVID because Dr. Jinam is going to come next. So anything I say about COVID, the boss is coming next. So I can barely try to say. But what I like to divide it is I heard a lot of complicated talks about insulin and COVID and steroid. In a nutshell, very simply, if the patient is already undergoing an active infection, which is COVID, which is known to have a viremia, and a very, very well-defined and aggressive post-viremic inflammation which is there, that patient automatically is a good candidate for insulin therapy, number one. Number two, I divide them into diabetic patients who have got COVID and are getting hyperglycemia, or a hitherto undiagnosed diabetic patient diagnosed as diabetes on the day when we investigated them with the CBC-CRP D-dimer for the COVID. Third category, absolutely fine. HbA1c previous could be 6, 5, 5.5, but having hyperglycemia secondary to glucocorticoid therapy. All three categories of patients do very well with a low dose of insulin sensitizer and insulin along with that. I think the titration depends completely on very individual and very, a vast spectrum of individual patient factors, but insulinization of these patients is essential. If a diabetic patient, a known diabetic patient is being given glucocorticoid therapy, except for that initial, those 3 or 4% patients who present with hypoglycemia at the beginning of ARDS, and then suddenly they shoot up with hyperglycemia, definitely all of them do deserve insulin. That is what I feel, sir. And anyways, very simply, even if I don't have as much knowledge as an internist would, as those specialists in the ICU would, I still know the basic that a patient in a hospital who is complicating, let me remove as much of the complicating drugs as possible, put them on something which is safe, known, well used, easily manipulable, easily titrable, and as accessible as insulin.
Manan, I agree with you fully. And I have one little policy in my life, which I'll share with you. I know it may be everybody's policy, that if there's any patient with any complication which is going to last for more than 3-4 days, then I would rather put the person, even for a short time, on insulin to permit me the flexibility of missing a meal sometimes or adjusting the next dose according to the response of the blood sugar. So if someone's admitted for a, let's say, cataract surgery for 12 hours, he's having a little bit of upset, then I don't change his oral hypoglycemics. But if he's going to get admitted for a disease like COVID, which may be 5 days, maybe 15 days, we don't know. In which case, the day I realize, I say, okay, let's take this out. Let's take the orals out and put insulin so that I can change his diet. And one thing about COVID, I don't want to overstep the limit of our, the ambit of our discussion, but COVID is a disease of water. And very many times our high blood sugars in COVID are due to dehydration. COVID itself leaks out water into the tissues. And therefore, the first thing I do is hydrate them in vengeance, almost double the amount of water that they would take in normal situations. So sometimes hydration itself brings the sugar down to acceptable levels. But hydration plus insulin is the surefire way of keeping good keeping normoglycemia during an episode of crisis. Is there anyone else like to ask question?
I think, we will, put questions. I think we'll direct it on Manan's email because we are definitely falling short. Sorry.
Yes, no, that's perfect.
Thank you so much, everybody. Thank you so much.
Thank you, Manan, and thanks everybody for listening in. All the
Thank
very
you, Dr. Gokani. Thank you, Dr. Gokani.
Thank you, Bharat bhai.
Merchant.
Yeah, sir.
Merchant.
Yeah, good afternoon, everyone. Now we have a fantastic speaker, Dr. Jinam Shah, who is an interventional pulmonologist. And he's attached to Bhatia Hospital, Wockhardt Hospital, Saifi Hospital. and he has done his MBBS, MD, DNB, and FCCP from USA and EDRM from UK. And he has done a fellowship from China in interventional pulmonology. And of course, the interventional oncology for the lung cancer. And his name has come in the Forbes magazine, the first 30 frontline warriors. So I think he deserves a big hand from all of us. And he will give us the insight of the interventional pulmonology. I welcome Dr. Jinam Shah.
Good afternoon, everyone. It's a pleasure to be at this forum, and it's actually a very flattening experience. And I'm, talking in front of all the stalwarts, and especially talking after Dr. Manan Mehta is a very, very difficult challenge in itself. So, I'll just try to put across some few points. Basically, I specialize in interventional pulmonology. So interventional pulmonology is a very, very relatively a new field which deals with all kind of complicated interventions, complicated bronchoscopic, thoracoscopic procedure. 5 to 10 years back, this field didn't even exist in India, but it existed in the rest of the world. But in the last 5 to 10 years, there have been a lot of development in this field, and I have definitely developed a very keen interest in this field. So I'll be talking about interventional pulmonology. So you have heard about intervention cardiology, neurology, but till now there was no pulmonology. So now there is, definitely a different field which is labeled as interventional pulmonology. I have done my specialization in respiratory medicine, and then followed by 5 years of extensive training in this particular field. China is the word that I would not like to use now, but I have also specialized from that region also. So rather than being a didactic lecture, talking about what interventional pulmonology is, I would rather take the liberty to discuss few cases. That will give us a better idea that what is the thinking behind interventional pulmonology. So right directly, shooting to the cases, I'll just try to. Yes. So this was the first case. This is a 54-year-old female. She's a housewife. Complains of fever and weight loss for the last 8 months. So any guesses on the X-ray? I like to be, discussion based because I prefer it that way.
This is.
So, as we can see, there is some amount of paratracheal, opacity on the right side, right paratracheal opacity. So fever, weight loss, and the first thing that you would think about in Indian setting would be a tuberculosis in a lymph node, basically, right paratracheal lymph node. So yeah, so there was a CT scan was done initially, and there was a CT scan showed there was a huge right paratracheal lymphadenopathy around 4 centimeters in size, and there was no necrosis and no calcification seen. So most of the cases, if it's not Mumbai, it would just go in directly for a tubercular therapy. After 4 or 5 months, you realize what is happening, whether it is actually TB, it would respond. If it's not TB, it would be something else which would not respond. So this particular patient was from Mumbai, so underwent a CT-guided biopsy. You can see the course of CT-guided biopsy. You have to go from all across the pleura up to the lesion. That would transfer the entire lung parenchyma. So CT-guided biopsy was actually done in this patient, but it revealed nothing because it was probably it didn't reach the site, or the lymph node was not accessible. I'm not really sure, but it revealed inconclusive results. So what would we do in this kind of circumstances? There's a lymph node, big lymph node. There are no features of TB like necrosis, which is the most common symptoms of most common presentation of TB. And you have already done your first shot and CT-guided biopsy is negative. So what would you do in this circumstances would be? One option would be to start ATT, but is there any other option we could, get to a conclusive diagnosis? So this is a therapy that I do, that is an endobronchial ultrasound, that is an EBUS. Basically, it's revolutionized the entire field in interventional pulmonology. It's like a same bronchoscope with as a tip attached to an ultrasound probe. So what we do is we just do a routine bronchoscopy, go inside the trachea, and whatever is there around the trachea and the bronchi. There is background which is coming. Can we just mute everyone? I cannot hear clearly. Yeah. So what I do is just go inside the trachea, isolate the lymph node, and then take passes from that. So that is a very, very non-invasive way. It's like doing a routine bronchoscopy. I'll just show how it looks like. This is how the picture looks like. I'm inside the trachea. I'm touching the tracheal mucosa. I can see this big lymph node here. So this is actually a hypoechoic lymph node. What I'll do is I'll just measure the size, and then through the trachea, I'll puncture into that lymph node particularly, and then I'll aspirate material from that. You can see this needle which is there inside the lymph node. This is going back and forth in that particular node, and I'm aspirating at the same time. So what happens is I'll get a lot of material, and at the same time I can use a Doppler also. So if I'm confused whether it's a lymph node or whether it is a vessel, I can use my Doppler to differentiate between the two. So it takes a particular lymph node would take anywhere between 5 to 10 minutes only. And this procedure is done under local anesthesia. Sorry. Okay. Yes. So this procedure is done under local anesthesia and it is done under sedation. So you don't require any kind of complicated general anesthesia procedure. It's a daycare procedure. The person comes in, you do the procedure in 30-35 minutes. The sedation effect wears off in an hour or so. And after that, the patient goes home walking after that. So this particular patient, which we are discussing, the female who was middle-aged female with fever and weight loss, ultimately turned out to be a classical Hodgkin's lymphoma. This patient, the sad part was after the CT guided biopsy, the patient had put on ATT because, it showed inconclusive results. And because it is India, the most common etiology is going to be tuberculosis. So she was put on 5 months of ATT, fever persisted, weight loss persisted, didn't respond to any kind of therapy. After that, been to a physician, and the physician even started on the second line ATT. 3 months of second line ATT, no response. And subsequently, the patient was referred for an endobronchial ultrasound. So this kind of procedures can be done at the start of the therapy rather than waiting for that ATT to act, and rather than thinking that it is something else or it is something else like a lymphoma or anything else. So it's always better. It is an era of precision medicine. We are not in the age 60 years back where we didn't have any kind of equipment with us. Right now, it is an era where you have you have equipment with you, you diagnose that patient correctly, and then only you treat them. So it simplifies the entire decision making for you. So this is the immunohistochemistry, and everything was done. So it is not just the biopsy. You can do all the molecular markers. You can do the IHC. Everything is done on the same sitting, and you can see the amount of material that you get. The amount of material that you get is a very sufficient material. It is not like a very thin material. It is not an FNAC. You get cores of sample from the entire tissue, so it is good enough for a biopsy, good enough for a molecular marker, immunohistochemistry, everything. So you don't require a biopsy. It is just sufficient to do an endobronchial ultrasound. So now when we compare it to a CT guided biopsy, so what are the advantages? First, it is, live under vision. If you have seen a CT guided biopsy happening, it is not live. It is, you puncture and then you're taking blind samples from that. This is like a live procedure because you can see the patient, the respiration, the moving, and you can see the live puncture, and you can see even the material is coming or not. We have a Doppler to differentiate between the blood vessels as against to a CT guided biopsy because, you cannot differentiate between the blood vessel and a lymph node. So this is an advantage of a EBUS. Minimal complications. It's like a daycare procedure. The complication risk is next to zero. We can even target nodes as small as 5 millimeters. As against to a CT guide biopsy, you would require at least 2 centimeters of a lymph node for a good radiologist to biopsy it. The second advantage after that is you are doing a bronchoscopy also. So if you find a lung lesion, you can take lavages, you can take biopsies, you can do all the same things in the same sitting rather than just taking a biopsy. If you know the diagnosis of sarcoidosis, it requires 2 different areas of biopsy. So if I'm just taking the lymph node, I may not end up getting a diagnosis. So what I'll do a bronchoscopy, I'll take a lavage, I'll take a transbronchial biopsy, I'll take an endobronchial biopsy of the lymph node. So all the things together will give me a definite diagnosis rather than just going for a single lymph node. What I can do is I can take multiple lymph nodes also. So if I find a lymph node in the right side, if I find a lymph node in the left side, I can do multiple lymph nodes in the same setting. So that again is a big advantage because when we're talking about lung cancer, what happens is staging of the lung cancer depends on the number of lymph nodes which are involved. 4, 5, 6, 7. So that is also very important. So if I'm knowing that this lymph node is involved, I would probably go in for a surgery. If multiple lymph nodes are involved, I would not plan for a surgery. So this is an advantage of an EBUS. So everywhere you see it's a complete package. The complication rates are minimal. You can do multiple procedures. You can do all kind of procedures that you want together in the complete bronchoscopy setup. So this is an advantage of an EBUS over a CT guided biopsy. I'll just skip this slide. One more advantage is that we can even do it in pediatric patients. As we can see, there are a lot of lymph nodes which come in even pediatric population. The problem is that the gastroenterology probe is a 14 millimeter diameter. So in pediatric patients, that probe could not go through the esophagus. But what we can do is we can put that same scope, the EBUS, that is an endobronchial ultrasound probe, into the esophagus and take biopsies from the carinal lymph node. So I'm using a bronchoscope to enter into the esophagus and take biopsies from that because it is thinner. It is 7 millimeters in size as against to a GI scope, that is a scope which is around 14 millimeters in diameter. So again, I can easily do all those kind of maneuvers because I have vision. Because when I'm putting it inside, my probe is telling me where am I, whether I'm in the esophagus, which lymph node I've reached. So it's like a dual pathology. I can enter the esophagus, I can enter the trachea, and I can do all kind of lymph node stationing. The only thing that is important, I can only target lesions which are around the trachea, because my reach is only there. If it is touching the trachea, I can definitely put my scope, isolate the lesion, and take biopsy. But if it is far, I cannot do that. So this is only helpful for tracheobronchial lymph nodes. So this particular patient turned out to be this 3-year-old child. This is the youngest patient who have undergone an EBUS done by our center, and it turned out to be tuberculosis. But again, tuberculosis knowing is not enough in our current generation. It is whether it is a drug sensitive, whether it is a MDR, whether it is XDR, we need to know all those kind of things. And looking at a lymph node, no person on the earth would able to tell you whether it is an MDR or an XDR. What you need for that is cultures, and for a culture you need some sample. So this is how you get a sample. You just take a sample, you take it in saline, send it for gene expert, send it for AFP culture, and you get a diagnosis. So everyone would agree in today's generation, you cannot start ATT just on an X-ray finding. You need to have some definite evidence of tuberculosis. So this is as far as EBUS goes. It is it's a local anesthesia procedure. The cost is around 40 to 45,000. But if you talk about 8 months of struggle, 8 months of multiple visits and doing multiple different investigation and not coming to a diagnosis, if you have something like an upfront EBUS, that would save a lot of energy, save a lot of cost to the patient. So coming to the second case, again, a middle-aged female presented with left-sided chest pain and breathlessness. Only history of low-grade fever. There was nothing else. There was no history of TB or its contact. Only thing was in 2011, she was an operated case of CA breast on the left side, and she underwent a radiation therapy after that. Any guesses on the X-ray? What does it look like? So it looks like a left-sided pleural effusion. Everyone is muted, so we cannot hear anyone. So there is definitely a left-sided pleural effusion. So now the question arises, what is the etiology? Obviously, the next step that everyone would end up doing is, we'll end up doing a CT scan first, and then based on the CT scan, we'll tell a pleural aspiration. So in this particular female, we underwent a pleural aspiration. 500 cc of fluid was removed, and the fluid showed that it was exudative because the proteins were on the higher side. Lymphocytes were high, 96%. The only thing that was going against tuberculosis was the ADA level was little bit on the it was normal. It was not above normal. So as we know that tuberculosis, we need to fulfill 3 criteria, that is high proteins, lymphocyte predominant. Third criteria is going to be high ADA. So in this particular female, the ADA levels were normal. Gene export was negative. Cytology was negative for malignant SEP. What would we do next? We know that's a case of old malignancy, but we are not really sure what is the diagnosis, because even TB has come out to be negative, malignancy has turned out to be negative. So what we'll do in such kind of scenario is, I will do a medical thoracoscopy. This is the gold standard of doing a procedure, because I need again some tissue. Pleural fluid cytology is not giving me any yield. So I still need to confirm my diagnosis, because whether I need to put the patient on ATT or whether I need to investigate further, or whether it is probably a malignancy. So this is what it is done. This is a medical thoracoscopy. I'll just show you how it looks like. So this is inside the pleura. What you can see here is the lung, which is moving, because this is a local anesthesia procedure. It is done under sedation. It's like an ICD. I put it from the chest wall. I'll enter into the pleura. Inside the pleura, I can see both the lungs, that is a visceral pleura and the parietal pleura. You can see the small whitish nodules like structure. This nodule-like structure was something which was abnormal. So what I did is I just took biopsies from them. Initially, I removed all the fluid, so everything is crystal clear in front of my eyes. Then wherever these lesions are, I just take biopsies from there.
He is taking lava.
I'll just take biopsies from there, and once the biopsy is done, I'll send it for investigation. Investigation will include microbiology as well as histopathology. So any guesses what the diagnosis? Hello. Can you just put it on mute? I can't hear you. Yeah. So we just take a biopsy from this, and biopsy ultimately what would reveal is
malignancy.
Malignancy, absolutely. So what happens is I'm inducing a pneumothorax. I put in the tube. I put in the thoracoscope, I take biopsies from that. At the same time, I'm removing the fluid. So that gives me an added advantage. It's a diagnostic procedure as well as a therapeutic procedure. Now, once I've known that it is a malignancy, what will I do? Because obviously it's a malignancy, it is going to refill again. So what I did is I sprayed talc all over the pleural surfaces, and the talc would help in pleurodesis. So I've done a diagnosis, I've done a therapeutic procedure of removal of the fluid, I've prevented further relapse by doing a pleurodesis in the same sitting. At the same time, I've put in an ICD after that, and once the lung expands, I'll remove the ICD. So this is a complete package. Rather than roaming around the bush of not knowing what the etiology is, I can go inside and do all the things in the same setting. And again, it is not a GA procedure. I don't need a GA, I don't need fitness, I don't need a 2D echo, I don't need all those complications. The patient comes in, it's a daycare procedure again. Patient comes in, I can do the procedure. Only thing is, because the ICD is there, I would like the procedure, like the patient to be in the hospital for a couple of days till the time the lung expands, and I'll remove the ICD and send the patient home. So this is yeah. So as we all know, pleural fluid cannot yield a complete diagnosis. 40% of the pleural effusion only you can get a diagnosis, and 60% of the mesothelioma cases you will miss out if you are not doing any biopsy. As we all know, whenever the person comes with a pleural effusion, when we do a pleural fluid aspiration, how many times do you find the gene expert is positive? How many times you have found the cytology to be positive for malignant cells? Hardly 10 to 20%. Most of the cases turn out to be negative. Whenever there is element of doubt, I can understand a young person, 20-year-old, come into a clinic, fever, weight loss, you probably think about tuberculosis. If it's fitting all the criteria, you might start on tubercular treatment. But what about the same thing, 60-year-old female? You are not really sure whether it is TB or not. So in those kind of circumstances, it is better that you do a thoracoscopy, confirm the diagnosis that it is tuberculosis. At the same time, you need to rule out whether it is drug sensitive tuberculosis or a drug resistant tuberculosis. You can do all those things at the same sitting. You are giving a patient a complete diagnosis, and your mind is clear that what you need to do next for the treatment aspect. So what are the important points? Not all pleural effusions are due to tuberculosis. ADA level which is normal is strongly against tuberculosis. So always think twice. If you find that the ADA levels are normal, tuberculosis is practically ruled out. You need to find other causes. At the same time, high ADA does not mean tuberculosis only. You can have that in malignancy, you can have it in lymphoma, even in parapneumonic effusion, empyema. Every condition can have high ADA. High ADA does not mean TB and you start the patient on tuberculosis. It has to fit a clinical picture that it is tuberculosis. Or you find a positive for microbiology. If you see a TB bacilli, then obviously you're confirmed with the diagnosis. Early intervention is the key, and thoracoscopy is the gold standard. Not many people are aware that thoracoscopy is possible. Not many people in Bombay or pulmonologists in Bombay are doing this procedure. There are hardly any few. That is why the awareness for this procedure is very less. As against to a surgical thoracoscopy, a lot of people are doing it, but they are predominantly doing it in a VATS. There are 3 ports. It's a GA procedure, and it's a very time consuming as well as a very costly procedure. This is how an instrument looks like. It's a very simple instrument. It's a single arm. You just dissect it like the way you put in an ICD. Dissect the chest wall, put in the trocar, put in your camera, go and visualize the entire pleura and take pleural biopsies. It's a very simple, it's not a complicated procedure. This is how it looks like. One more case. This is typically caseous necrosis, caseous material that is seen in the pleura. This turned out to be tuberculosis. You can see these flimsy adhesions that are there, the small fibrin threads. So one more advantage of thoracoscopy, I can break all those threads. So it prevents the further fibrosis in the pleura. If I have done an early thoracoscopy, I'll break all the adhesions, so the lung expands and there is no residual fibrosis. Again, a very important concept, because if you don't do that correctly, there would be a lot of fibrosis, and you will find that post-TB sequelae, lung is collapsed. There is a lot of mediastinal shift which is happening, and the patient might develop breathlessness later on in life. So this is also again important. If you're doing an early intervention, you can do a lot of good work. So where does my medical thoracoscopy help? In an undiagnosed pleural effusion, breaking out adhesions, lung cancer staging, and obviously, as I told you, in pleurodesis, in a malignant pleural effusion as well as pneumothorax. If there is a recurrent pneumothorax, I can still go inside, do a pleurodesis, spray talc, and my job is done. So this is as far as thoracoscopy is concerned. The next part is going to be our case number 3. If anyone can just tell me what is there on this X-ray. So this young male, 22-year-old male, presented in the emergency department with stridor. Only significant history was 3 months back. the patient had underwent a mechanical ventilation for Guillain-Barré syndrome, recovered completely, immunoglobulin given. After 3 months, the patient presented with stridor in the emergency department. So the X-ray, retrospectively, you can see there is small, constriction of the trachea as the arrows pointed out. So what was the next step that I did? I did a bronchoscopy. So bronchoscopy showed that there was significant narrowing of the trachea. The trachea is normally a big size, that is in 18 millimeters, but this is narrowed to almost 4 to 5 millimeters in size. So once I see this, sorry. So this is a very much narrowed trachea. I cannot even enter my bronchoscope. So what I'm doing is I'm cutting that fibrosis. This is all bronchoscopically. And then I'm passing my rigid bronchoscope through that entire stenosis so that I bypass it and it dilates to a complete extent. And what I'm doing it after that is I'm just clearing up all the secretions and I'm putting in a stent. This is a silicone stent, the white color silicone stent. It's an inert stent. I'll put it in that thing and I'll just station it in that particular area. So now you can see the distal area of the stent is completely patent. Even the proximal area now I'm seeing is completely patent. So which was a small stenosis initially, I've just put in my rigid bronchoscope. I've dilated the entire stenosis and I put in a stent. You may ask why a stent? Because we know that stenosis tends to recur again. So to prevent the further stenosis, what I need to do is I need to have something which holds onto that stenosis. So I put in an inert silicone stent. That stent will remain almost for a year or more out there, 1 to 1.5 years. And then once the airway matures, all the fibrosis matures around it, the airway patency remains and I can remove the stent after that. So this is a beautiful technique. Till now, only thing that was available was resection and anastomosis of the trachea. What you do is you just cut off that entire trachea and rest of the areas of the trachea, you close it together. But now we have a modality where we can do this non-invasively. You just do a bronchoscopy, open it up, and after a year, you can remove the stent. It is done under general anesthesia. It is not a local anesthesia procedure because you need to know, you need to ventilate the patient simultaneously, because if it's a stenotic trachea, if you just do not ventilate, there are chances that the hypoxia and patient may arrest. So it's a very, 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 very complicated procedure. Very few people, would even able to dare to do such procedures. But with a lot of experience, I have been doing multiple cases of this. It's a very challenging thing, but it is very rewarding because you can do something non-invasively. So this particular patient was kept on observation. 1 year later, the stent was removed. At the end of 3 years, the patient is now 25-year-old, completely normal, not having any symptoms, no stridor. And we have been doing, for the first 2 years, we had done bronchoscopic evaluation. That area was completely normal now. There is no stenosis at all. This particular patient was saved of the surgery. If you have heard about the surgery, resection anastomy is a very complicated surgery. What you need to do is cut the trachea. What happens is after that, you need to stick your chin to the chest so that there is no traction on that particular suture area. So for 6 weeks, the patient is doing this. Patient has to eat with a straw, drink with a straw. It becomes very complicated for the particular patient. So that is why this is something which is, non-invasive way of doing such kind of procedures. One more technique, one more case I'm just showing is, this is again, this similar stenosis. You can see it is completely stenosed, the trachea. So similarly, what I've done is I've put in a stent, and this time what I'm doing is, because the stent is not opening, I'm using my balloon. The same thing that you have seen in an esophagus, what I can do is I can put in a balloon in the trachea also. I, open it up so that entire stent opens up on table. So this is something like a silicone stenting. We generally use it for a benign airway disease. What you do for a malignant airway disease, I'll just come to that. So this is again an interesting case. Young female, 37 years old, presented with cough and breathlessness with mucoid expectorations in the last 1 month. And on examination, again, she was stridorous. Saturation was only 94% on room air. Auscultation revealed multiple wheezes all across the lung fields. Only significant history was in 2011. She was a diagnosed case of adenoid cystic carcinoma of the trachea. So the tracheal excision was done and resection and anastomosis were done 2011. 8 years after that, she presented directly with a stridor to the clinic, to the emergency department. So what we did is first just did a CT. So we realized that there is significant narrowing of the trachea. If you can see, I cannot point it. I don't know why. There is significant narrowing of the trachea, and there is around the trachea there is significant deposition of soft tissue. So that is the reason why the trachea was completely collapsed. So what I did was I did a bronchoscopy. You can see this bronchoscopy. This trachea is reduced to a slit. I can hardly even see the opening. It is completely narrowed and it is slit like. and there are secretions which are clogging that slit again. So that is why the patient is completely breathless. So again, a very challenging situation. We don't know what to do because the patient is in stridor. I cannot operate because the patient is already having a resection. There is no trachea to operate for. So what I did is just did a bronchoscopy. I found out that there is a significant slit. So what I did is I put in a stent. This is how the stent looked like. So I'll first cross that juncture. I'll put in a wire, guide wire, which will help me enter my stent into it. Again, a local anesthesia procedure and some sedation. You can see that the patient is, moving actively. Now what I'm doing is I'm putting my stent through the vocal cord. This is the vocal cord. So my stent is going on the left side as well as the right side. And my stent is getting deployed. So now I've deployed the stent. This white color is a complete stent. I've put in a Y stent. This is like an inverted Y. One limb is going in the left side, one limb is going in the right side, and the rest of the limb is in the main trachea. As you can see that, it's stationed completely well. All the distal areas of the segments are completely clean. And now when I'm coming out, that entire stenosis which is there, it's open up. It is completely open. This is the SEMS, that is a self-expanding metallic stent. The beauty of this stent is it expands on its own. I just deploy it and it will keep on expanding so that the trachea will keep on opening up and it will open up to its normal size. So this is the the advantage of this SEMS. So once that deployed, we kept the stent for at least 3 to 4 months. And you can see that X-ray, the CT scan post the stent. You can see that the trachea, which was like a narrow slit, it has opened out now significant. The patient improved immediately on table. Patient was given some steroid to decrease the edema. And after that, what was done is we had given radiation therapy. So once the radiation therapy was given, the entire soft tissue which was there around the trachea also resolved. And after that, what we do is we remove the stent. I'm just holding this. This is how, we just catch hold of that stent. And what I'll do is I'll just pluck it off. So beautiful thing. Patient came in stridor. I put in a stent. I bought time. I gave radiation so that after radiation, that entire soft tissue was, minimized. I removed the stent. So patient was given a complete good quality of life. I'm not saying it is a treatment of choice. It is always a palliative procedure because it is done in an emergency setting where the patient is not able to breathe. My only intent is this procedure is to give a patient a good quality of life. Imagine this patient in stridor. If we keep at home and without doing any procedure, the patient is going to have a very, very bad quality of life. To improve this quality of life is something that I can do a stent. Stenting is again can be done for benign diseases where it has beautiful results, or for malignant diseases where it is done as a palliative setting where I can improve the quality of life of the patient. So one more case. This is a middle-aged, young male, 43-year-old male, history of tuberculosis 3 years back. Now gradually progressive increasing breathlessness. Any idea what the X-ray looked like? Any guesses?
Yeah, it is a right-sided, either a pleural effusion looks like.
So one important differentiation, why a pleural effusion?
Because of the past history of tuberculosis.
Yeah, so very, very unlikely a patient of tuberculosis has a relapse and develops a pleural effusion. Generally, the relapses are always a parenchymal relapse, never a pleural effusion. So in this particular case, if you can see the trachea, I am not able to point it out, but if you can see the trachea is shifted, pulled to the same side. The right side is completely opacified. If you see the trachea is pulled to the same side, that means it is a lesion which is pulling. So it is either a collapse or there is some kind of lesion which is obstructing the bronchus. It cannot be a pleural effusion. Pleural effusion generally would push the trachea on the opposite side, not on the pulling the same side. So this is a lung collapse. This was a clear-cut diagnosis to me. Right-sided whiteout lung, there is a lung collapse due to endobronchial lesion. There's something which is obstructing the bronchus leading to a collapse. So what I did a bronchoscopy. So this is a bronchoscopy. What I see is this is a right bronchus and this is the left bronchus. The right bronchus is completely obstructed by a soft tissue mass-like lesion. So what I'm doing is I'm using a snare now. What I'm doing is using a snare and I'm cutting out that entire lesion. So once I cut out that entire lesion, I pull it out. Now you can see that lesion, that area of the right bronchus has opened up, but it's still constricted. So what I did is again open it up with electrocautery knife. And after that, I'm just putting in a balloon, the same kind of CRE balloon which is used in the esophagoscopy. I'm using it in a bronchoscopy. So what I'll do is I'll put in a balloon and then I'll inflate it. So once on inflation, what will happen that stenosis get gradually dilated. And once the stenosis is dilated, my airways opens up and I'm able to pass my bronchoscope very easily. So once, once the airway dilates, you can see now that, this is a big enough opening. My bronchoscope can pass easily through this now. And once I'll pass my bronchoscope, I can, do all kind of maneuvers in this. So what happens is the lung gets completely expanded because the lung was collapsed. There was, patient was feeling breathless. The lung was collapsed. The patient was not able to walk. So now after doing the procedure, the patient is completely better. The lung, as you can see, the lung has opened up significantly. You can see a lot of variation. The only thing is the fibrosis doesn't go away. This is just a procedure to open up the lung. The lung fibrosis, which is there due to tuberculosis in the past, is going to remain any which ways. You cannot, change the fibrosis of the patient. So what we did is repeated bronchoscopy was required. Second time we went inside, again there was some fibrosis, some stenosis. So I again opened it up. So after 3 sittings, when we repeated the bronchoscopy 6 months later, there was no stenosis after that. So this was a therapeutic procedure to relieve his breathlessness as well as opening up the bronchus and didn't recur again. So again, it's a beautiful procedure where we can give good quality of life to the patient. And this is something which is not known. You would never hear something like this. Bronchoscopic, excision of that stenosis, dilatation of that stenosis is never heard till now. So, one case which is, very commonly presented to your clinic is hemoptysis. 42-year-old male, history of hemoptysis around 100 ml in the last 3 days. You must have seen this very commonly in your clinic. Patient comes with hemoptysis. You do an X-ray, you find that there is some lesion in the right side or the left side apex. So generally, you're not sure what to do. Generally, you end up doing a sputum gene expert. You do that, it turns out to be negative. You are again confused whether to give ATT or not. That is the first question. Second question is how to treat that hemoptysis. If it bleeds torrentially, you may even lose the patient. So you need to do something to prevent that hemoptysis. This particular gentleman had received 3 times ATT. Every time he would develop hemoptysis, he would go to the physician, start on ATT, give 6 months, may or may not have resolution of hemoptysis. Again, go to another physician. Again, ATT, second line, first line, third line, all kind of ATTs were given. But the problem is never anyone had, even bothered about isolating the organism, whether it is tuberculosis or not, whether it is drug resistant, drug sensitive, what is happening. So the patient presented finally with me after 3 attempts of failed to ATT. What I did is I just did a CT scan. The CT scan showed me this typical, you can see the red arrow. This is typically a fungal ball. You can see a black color crescent at the bottom of that lesion. This is an air crescent sign. It is very classical for fungal ball. It means that any cavity in the lung, it is exposed to the environment. So what happens in the environment, there are a lot of spores of the fungi. It goes inside the lung, gets deposited, it grows there and it erodes the airway wall and ultimately leads to hemoptysis. So this is actually a fungal ball which is leading to hemoptysis. So what I need to do is control the hemoptysis and treat with antifungals rather than continuing treating with ATT. So what I did is so first before knowing what I did is what are the options we have. One is a BE, that is bronchial artery embolization. You can just go inside the artery, you can block that artery. It is a very high cost. Failure rates are 50% at the end of 1 year. And it is only a therapeutic procedure. You cannot diagnose. I would just go inside, do a BE, I would just stop that bleeding. But still, my diagnosis would still remain a query, whether it is tuberculosis, whether it is something else. As against to a surgery. The second option would be a surgery. Just go inside, remove that entire lobe, upper lobectomy or lower lobectomy. Just remove that entire lobe. It is very complicated procedure. Again, high morbidity, mortality, very high cost. Expertise in this current setting is not very good. And if it's a patient is infective, there are chances that the infection may spread in the other lung also. So what I did in this procedure was, I did a bronchoscopy. I went inside and I isolated that the bleeding was coming from the right upper lobe. So this is, you can see that specks of blood coming from the right upper lobe. So you can see the specks of blood coming from the right upper lobe. This is the right side. Active bleeding is seen from there. And you can even see some mass-like lesion out there. So what I did is I just took a lavage first. So what happens is I get a diagnosis. I'll just take some secretions. I get a diagnosis that it is whether it is tuberculosis or not. After that, what I'll do is I'll just go inside, put in a glue from where the bleeding is coming. I'll just go inside, put in a glue. It will block that entire area from where the bleeding is coming. So I've done two things. First thing that I've done is done a diagnosis by taking some lavage. Second thing that I do is I put in a glue where it will stop the hemoptysis completely. So both my things are done at the same sitting. The glue, I'll just show you how it is done like. I'm sure. See, this is how the picture looks like after the glue. I put in a glue in this area, particular area, and after that, you cannot see any kind of bleeding coming from there. And the glue organizes over a period of time. So after 24 hours, it becomes very, very hard, and it doesn't allow any kind of blood to spill out. So it prevents the other lungs also from getting aspirated and having a tremendous complication. So this particular gentleman, when we got the lavage report, it turned out to be negative for AFB. Gene export was also negative. The culture was only negative. So only thing I did is treated him with antifungals, and after that there was absolutely no bleeding till today. After like 2 or 3 years post follow-up, the patient has never happened bleeding again. Yes. So now there are few more cases that I like to discuss. One is a foreign body removal, 1.5-year-old child. I do all this kind of procedures also. History of, I'll just go quickly. Okay, there is some problem with the, there is some error. So this was a peanut aspiration. There was a mungfali with the child had aspirated in the right trachea. I did a rigid bronchoscopy, went inside and removed that peanut again. The only thing bad about this child is his dadi used to give him peanuts every now and then. And again, after 6 months, again, there was similar history of peanut aspiration. Again, went inside and again remove it. So just, always remember that peanuts are not safe for kids. Please don't end up giving them peanuts, especially in a children who is less than 2 to 2.5 years old. So this is very, right from pediatric age group to adult age group. This is something like a denture which was aspirated in a adult. Again, with a rigid bronchoscopy, removed it from the right bronchus. These are not very simple procedure. It seems very simple that you just go inside, pick up the foreign body, remove it. There are a lot of challenges. It gets stuck. It gets, macerated. It breaks down. A lot of complications that can occur. So this was one of my favorite cases. I wouldn't take, much time in this. This was a 48-year-old. This is the first time ever attempted in India, actually. This is a 48-year-old male, history of CA esophagus, underwent a Macnion's esophagectomy. So what had happened is after esophagectomy, there was a fistula which had developed between the gastric end as the tracheal end. You can see this big fistula. So the stomach which was pulled up had a fistulous connection with the trachea. So this is the tracheal view, how it looks like. So entire fistula was developed between the gastric end and the tracheal end. It is very bad. The patient had aspiration because obviously there is a fistula that all the stomach contents would come into the bronchus and they would lead to pneumonia and lead to aspiration. The patient was very, very cachexic, running fever, no other options. So what we did is we put in a novel implanter device. Implanter device is like a device which is used to close the ASD. That is the atrial septal device. It has two limbs, one limb on the one side and the other limb on the other side. So what I'm doing is I'm just putting it through that and I'll just show you quickly. This is like a ASD device. It has two dumbbell-like shapes. So I'm closing one end from the bronchus end and the other end I'm closing from the gastric end. So both the ends closed completely and that fistula is closed. There was no option of surgery in this particular patient because this was a patient on advanced malignancy, already done what procedure, cannot operate it further. So we did this. This is how the second part looks like. So I'm covering it from the trachea also. So both the areas get completely sealed off and there was absolutely no fistulous communication left after that. The patient was able to eat. There was no aspiration and the patient survived for 6 months after this with a good quality of life. This is an implanter device which is used to close a tracheobronchial fistula, which is, first attempt in India. There have been at least 7 to 8 case reports worldwide literature, but this is the first time that we are done in our setting.
5 minutes, Janam.
Yeah, final, this is for a couple of slides now left. Interesting concept of cryobiopsy in ILD, interstitial lung disease. Many times, you have had patients in your practice, family practice that, comes with interstitial lung disease. Always confuse what to do because one chest physician or one physician will end up giving pirfenidone. As Dr. Bharat would, rightly agree with me. There are a lot of options. Pirfenidone, nintedanib, there would be options of steroids, there would be option of other immunosuppressants. whether to go in for a transplant, what is the diagnosis, whether it is hypersensitive pneumonitis, whether it is idiopathic interstitial pneumonia. There are huge number of differential diagnoses in an interstitial lung disease. Coming to the basic concept of diagnosis, if you tell me if the patient with fever and fever and chills come to you in clinical practice, what will you do? Obviously, what you're going to do, you are going to do a PSMP, you're going to do a dengue test to find out what is the diagnosis and then only treat it, because you're not really sure what is the diagnosis. It can be COVID also in this current scenario. Similarly, the concept in interstitial lung disease is it can be anything under sun. Till the time I do a biopsy, I would never be able to understand whether it is HP, that is hypersensitive pneumonitis, whether it is IPF, that is idiopathic pulmonary fibrosis, whether it is CTD associated ILD, whether it is there are n number of pathologies that can come across. So that is why the best thing that can always happen is to take a biopsy from the lung. Till now, you would never hear across a lung biopsy because it is very, very risky. You would have heard that surgeons, do a VATS, that is a thoracoscopy, and take a lung biopsy. But that is not very safe because patient in an ILD already having a compromised lung function. If you do a procedure under general anesthesia, there are very high risk of complications. So that is why most of the people, most of the physicians as well as chest physicians don't end up doing a biopsy because it is high risk. But now we have something known as a cryobiopsy. Cryobiopsy is a recent tool. What happens is it just has a separate probe. It is a probe, it is attached to a bronchoscope. We just enter inside, do a bronchoscopy, go inside the trachea, go inside the bronchus, go inside the particular alveoli, just do a biopsy. It gives me a huge chunk of biopsy. This is how big the biopsy looks like. The VATS, obviously a surgery sample would be very big, but when you compare it to the cryobiopsy, the samples are very, very big. So it will give you a definitive diagnosis, because the treatment depends upon the diagnosis. If it's a hypersensitive pneumonitis, I would like to give him steroids. If it's IPF, I would like to give him nintedanib or a pirfenidone. If it is a CTD associated ILD, I would like to give steroids. If it is a drug-induced ILD, I'd like to give nothing actually. Even the prognosis, you need to tell the patient what is the quality of life, how far I'm expecting his survival. All those things you need to discuss with the patient. If you don't have a biopsy, there is no way that you can go ahead with this kind of counseling of the patient. So that is the end of my presentation. I just leave with the last slide is the best way to predict the future is to create it rather than just waiting and watching for it. Thank you very much for patient listening. I would be more than willing to answer any questions.
Thank you, Dr. Jinam Shah. You did a wonderful job, and I can tell you the thoracic surgeon will be jobless. What you are doing, the interventional pulmonology. Shall we keep the answer, the question later on, Janak Bhai, or we'll have questions? Bharat Bhai, any question there?
What I feel is, we just take is what you call questions on our email and then we'll fire it.
Okay. Yeah, Dr. Jinam Shah, thank you very much. Yeah.
Just let me see if there are any questions.
Yeah. But it's a fantastic lecture, Dr. Jinam Shah. We really enjoyed it. And the way you are doing so many procedures, it's really mind-blowing. Thank you.
अभी कौन सा slide दिखा रहे हो?
Actually,
sir, there are no
questions. One second, sir. There are no questions.
Yeah, slides.
Dr.
What is discussed?
Pramita, please. Sir, there are no questions. Everyone have just appreciated your this thing. Nice presentation, excellent presentation, excellent information, superb. Everything. Only that is the thing. I think.
Thank you once again.
Congratulations. I would love some questions, because I would want to know your thinking,
No, it's a wonderful job you have done, sir. Excellent job. Yeah.
Questions.
So one of the doctors has asked that, what is the risk of respiratory arrest when you're doing these procedures, sir?
कौन सा कोई भी slide नहीं था. I was always through. एक भी question नहीं.
मैं screenshot ले रहा हूँ, ma'am. I'm just putting it on. I'm just taking screenshot.
There is no nothing, because this lady is seen now who is in video. Question answer. She's Sunita Mangalik. She's asking questions, I believe.
Yes, sir.
Okay, shall we go on the next topic, Janak? Or there is still some queries?
Yeah.
No queries, no?
No queries.
Okay. Thank you, Dr. Jinam Shah. It was a wonderful lecture. We really appreciate you took a wonderful journey of various procedures you are doing. Thank you once again. Now our next topic is on hypertension, and that is a panel discussion we are going to have. And panel discussion is going to be conducted by none other than Dr. Sunita Manglik, who is practicing at Worli for last 28 years. And she has done her MBBS, FCGP, DNB in family medicine. And she has presented many papers in our conference. The last paper in the last our annual conference. Wonderful job she has done is the geriatric care. And she has written some chapters on psychiatry in our coming next year, the annual celebration. And she's written some chapters on psychiatry, right from anxiety, depression to schizophrenia, which I think you people will get it. And of course, she is multifaceted personality, and she has acted in one show which Dr. Bharat Bhatt, who is the director, and I'm sure in our next conference he is going to have again one more play with Dr. Sunita Manglik. And I welcome Dr. Sunita Manglik. Stage is all yours.
Thank you, sir. Thank you, Dr. Merchant. I will just rush through the introduction of the panelist. Dr. Mahmood Merchant, am I audible?
Yeah,
you're audible.
Yeah. Dr. Mahmood Merchant, practicing in Bandra West for the last 49 years. He has been the past president and present scientific convener of GPA. He's the recipient of many prizes in various annual conferences of GPA and FFPI. And he's the only GP who has taught ECG to more than 5,000 medicos in Mumbai, Thane, and Pune. In fact, as far as we are concerned, he has the entire clinical medicine on his fingertips. Dr. Preeti Bhargav, a no-nonsense doctor. She is a family practitioner from Andheri West. She has been conducting CME programs in Nanavati Hospital for many years, and she is one of the pillars of our GPA conference scientific committee. Dr. Vivek Bhosle, a family practitioner from Kalyan, practicing in Kalyan since 30 years. He has done all the possible courses of PHFI. He is the CME convener of IMA Kalyan. Dr. S.B. Acharya, our fourth panelist. He is a family physician practicing in Dombivli since 30 years, and he has special interest in diabetes and hypertension. Dr. Sarang Apte, the youngest panelist, he is practicing as a consulting physician in Thane. He's attached to many hospitals and also corporate group of Tata Motors Hospital. He has a publication in the field of adolescent medicine, and he has read papers in infectious disease conferences. So these are our panelists, and our expert, Dr. Manan Mehta, has been introduced, and he will contribute to the answers as and when required. Dr. Mehta, you can hear me?
Yes,
okay.
Ma'am. I'm looking forward to, but after the introductions you made of the panels, I think I will stay out of your way as much as possible, because we have big wigs tonight.
Before I set the ball rolling, a few words about what is called lockdown hypertension. The incidence of hypertension in this pandemic due to unhealthy eating, sleeping habits, and lack of exercise. Lockdown hypertension. Sometimes due to the unavailability of antihypertensive medicines, as well as the anxiety and insecurity due to loss of income, as well as social isolation. Other term which is prevalent is IT hypertension, which refers to the increased incidence of hypertension in the young generation who are spending long hours in front of the laptop, forgetting about healthy eating, sleeping, and exercise. So, Dr. Janak, please start sharing the slides. And till the slides come, I will start asking questions. So, can I start? We have a long way to go.
I think I've shared it. Is it coming?
No, Dr. Mahmood, can I start asking questions? What happened?
Slides are not visible.
Yeah, but
now?
Now they are visible. Yes.
Okay.
Yeah.
Okay.
Next. Janak, next slide.
Yeah, do it.
So the first question is to Dr. Merchant. And this is, what is normal hypertension? What is normal blood pressure? When do we call high blood pressure or hypertension?
Yes.
And Please answer the first part.
Okay, see, according to the American Heart Association and GNC, the normal blood pressure is systolic less than 120 and the diastolic less than 80 millimeter of mercury. Now, if the blood pressure is going to 129 and the diastolic 80, we call elevated blood pressure. But it is still the normal blood pressure that you can correct it. Then there is something called 139 by 89. That is 139 systolic, 89 diastolic, and that is called stage 1 hypertension. And once it crosses 140 above, 140 and above, and 90 and above, then it is called stage 2 hypertension. So this is the present thinking.
Okay. Okay, sir. Now, how do we diagnose hypertension in the first time detected high blood pressure patient across the age group, right from 18 years to beyond?
Now, you see, the hypertension, we can divide either it is essential or it is secondary. Now, if it is first time, if it is the first time detected, then I think it is our duty that first reading should never be taken. If it is 140, 90 or 150, 100, call the patient again at different time and take at least 3 readings. And if the 3 readings are high, then we may think that whether this person got hypertension. Because in the younger age group, we just can't start the treatment because they have to take medicine for quite some time.
Okay, sir. Yeah.
So we like to investigate.
Okay, sir. So the next question now goes to Dr. Preeti. Dr. Preeti?
Yes, Dr. Sunita.
The next. So what is primary and secondary hypertension, and how do we rule out secondary hypertension when the patient first presents?
So when we find no cause for the hypertension in the person, we call it primary, and 90% of the times it is primary. When there is an underlying cause for the hypertension, it is called secondary hypertension. So when the patient first comes to us, there are usually 2 situations. You know, the patient does not come saying he has blood pressure. He comes with some symptoms. And in the course of time, when we are examining him, when we check his BP, we realize there is high blood pressure. So depending on those symptoms and depending on our clinical examination, we can deduce whether there is some cause for that blood pressure, right? And depending on that, then we can decide what is the cause of that blood pressure. There is a second situation nowadays when patients have done their health checkups and they come, in their health checkup, they found that their blood pressure was high. Now, in both the situations, we always send the patients for a detailed detailed checkup, blood checkup, all the checking for thyroid, diabetes, renal profile, liver profile, because for 2 reasons. One is we want to know whether there is an underlying cause for blood pressure. Second is if the blood pressure has caused some target organ damage in them. So considering all this history, clinical examination and the checkup will tell us whether there is secondary hypertension.
Okay. Can secondary hypertension develop later in life in a known case of hypertension on treatment?
Yes.
Yeah.
One example would be a case of, say, atherosclerosis, later on leading to renal artery stenosis and causing high blood pressure. One point I would like to mention, talking of secondary hypertension, is taking drug history. There are certain medicines which can lead to high blood pressure. For example, patients taking NSAIDs chronically, right? That could lead to blood pressure.
Absolutely.
And among the secondary hypertension causes could be, of course, obstructive sleep apnea, thyroid issues, pheochromocytoma, renal issues. So these are the various.
Yeah. Thank you. Next. So my next question goes to Dr. Vivek. Dr. Vivek, what is the role? What is lifestyle management? The question.
Okay. Systolic hypo, isolated systolic.
Okay, sorry. So what is isolated systolic? Yeah. What is isolated systolic hypertension and what is its significance? Dr. Vivek?
Yes, it is usually the diastolic blood pressure is less than 80, it is always normal. But the systolic pressure raised up to 130 and above. And it is generally seen in the adult above 60, 65 years. And the main cause is atherosclerosis. And
Dr. Vivek, just a moment.
Elasticity of the arteries goes down. and anemia, diabetes. In this situation, we see this isolated systolic hypertension.
Yeah, but the systolic
And
in this,
I think the best drug of choice.
no, wait. Dr. Vivek, pause. So in isolated systolic hypertension, you rightly said that the diastolic is more or less normal, but the systolic pressure is very high, like more than 160, 170, 180,
160,
right? Yeah, not, so 130, 140, 150, it's far higher.
It is above, it is above 160 also.
Yeah. And its significance, it could lead to MIs and stroke and
it can lead to other cardiac problems.
Yes.
Yes. And treatment is again a calcium
no.
blocker.
Hold on, sir. Yes. It will come later. Yes. Okay. Next slide, please. Dr. Acharya.
Yes.
What is lifestyle management, LSM, and DASH diet in the non-pharmacological management of hypertension?
This is one of the method. In fact, stage 1 hypertension can be treated with lifestyle modification. And lifestyle modification includes weight loss, sodium restriction, potassium supplementation, alcohol moderation, increase in physical activity, stress management, yoga, smoking, and tobacco cessation.
Yeah. And what the diet, DASH diet?
Regarding DASH diet, the DASH diet is known as dietary approach to the control the hypertension. It consists of the high fruits and vegetables, low fat dairy diets, whole grains and nuts, poultry and fish, little red sweets, sugar, little sugar, or less of the total saturated fats and cholesterol, less of sodium and high of fiber diet, and high calcium and magnesium.
Yeah. Okay, thank you.
Ma'am, I'd just like to add here, in the DASH diet, when we talk about salt restriction, it becomes very difficult to tell the patient their salt targets because we can't calculate the salt. So what I do is for the first 48 hours to 72 hours, 3 days, I tell the patient to cook the meal without salt at all. And then I give them 5 sachets of 1 gram salt.
Yeah.
So depending on how many they use. Yeah. Yes, ma'am. You can add as per prandium, as per taste. Yeah. So you can keep a target. I think that works practically.
And that's a very good suggestion. Yeah.
I think just one suggestion which I would like to make, the drug-induced hypertension, even abuse of nasal decongestant sprays also contribute to hypertension.
Yes, sir. True. The next question, Dr. Sarang Apte.
Good afternoon, everyone.
Yeah. What are the ideal candidates? Who are the ideal candidates for only non-pharmacological management of hypertension? And how long can we give this non-pharmacological management?
So basically the persons who are asymptomatic and those who are diagnosed newly for the hypertension, that is blood pressure more than 140/90, they are the ideal candidates for non-pharmacological management. In these patients, the blood pressure should also be monitored for continuous rise of the blood pressure or the readings. Second thing is, in this type of candidates, we can start with, as just mentioned by the sir, about the dietary restrictions, including salt intake and everything.
Yeah.
The exercise.
Yeah, that we have spoken. Yeah, that comes in non-pharmacological management. Thank you, Dr. Sarang. Next slide, please. So, Dr. Preeti, drug of choice in first-time detected hypertension if there are no other compelling indications irrespective of age. Preeti?
Yeah, ARBs are the drug of choice, provided the patient is not in the reproductive age group. The girl is not in the reproductive age group.
Okay. Next slide, Janak? Yeah. Vivek, why do we prefer an ARB over an ACE as the first drug of choice?
ARB? Yes. ARB is a better tolerated drug, and it reduces the microvascular complication also. And the main side effects of the ACE inhibitors, which is very commonly we see, is a dry cough, and it is not seen in ARBs. Even potassium disturbances, increased potassium, and allergic reaction, which is very common with ACE inhibitors, that is not seen in ARB. That is why it is the first drug of choice.
Yeah. So clinically, dry cough, which is very distressing. Yeah, which is very distressing, is less common in ARB.
Yes.
Next, please. Thank you, Dr. Acharya. Janak, next slide.
Yeah, already.
Yeah. Dr. Acharya, what are the renal parameters to monitor after starting an ARB? What renal parameters?
When we start with ARB or ACB, there are criteria the serum creatinine may go high or the potassium may go high. Now the serum creatinine levels 30% or more than the baseline. Then the contraindication for continuing the ARB or ACB.
Then we are forced to shift to another group of antihypertensive drugs. Janak, next slide, please. Dr. Sarang, drug of choice in a young female patient, marriageable age.
So in these young females, usually the calcium channel blockers are preferred, such like amlodipine and other medicines are the drug of choice.
Amlodipine. Okay. Amlodipine or cilnidipine.
Just here, apart from amlodipine and cilnidipine, in a young lady who might be looking to start a family, considering sympathetic factors are also important, because then a beta blocker can be also, a specific beta blocker can be a good drug of choice, which she can carry over to her gestation.
In pregnancy. Yeah. Pregnancy as such, we use labetalol is the most frequently used drug.
Yes, ma'am.
Okay. Dr. Merchant, amlodipine is the commonest used CCB. What are its side effects?
Yes, amlodipine the commonest side effect I have seen in my practice is edema of the feet.
Yeah.
It is the commonest side effect. The other side effects are headache, palpitation, constipation, and sometimes even the hypertrophy of the gums. So that is the side effect I have seen in the amlodipine.
Okay. And what is the dose equivalent of cilnidipine in case we switch over?
Now, if there are 2.5 milligram of amlodipine is equivalent to 10 milligram of cilnidipine. So you have to adjust the dose accordingly. If you are giving 2.5 of amlodipine, then give cilnidipine 10 milligram, which you can give. Yeah.
Okay. Thank you. Janak, next slide, please. Yeah. Preeti, why is sublingual nifedipine given up in the management of hypertensive emergencies?
Yeah, sublingual nifedipine can cause a sudden and unpredictable lowering of blood pressure, and it can thus precipitate ischemic event in the heart. That is why it has been given up. We have better drugs now.
Or even a stroke. Stroke. Thank you. Yeah. Dr. Janak, we have missed the 12th. Slide number 12. Yeah, Vivek. Uses and side effects of thiazide diuretics like hydrochlorothiazide or chlorthalidone. Uses and side effects. Yeah.
Yes, the side effects is first is hyperlipidemia and hypokalemia, hyperuricemia, and even hypercalciuria also, because and sometimes it causes hyperglycemia also and hypovolemia. These are all side effects of the thiazide groups.
And we mainly use these diuretics in systolic hypertension.
And edema, where we see the edemas and all.
And in heart failure.
Yes.
Congestive heart failure. Yeah.
Congestive, right.
Yeah. Next slide, please. Yeah. Dr. Acharya, indications and contraindications for the use of beta blockers.
The indications mainly include angina, mitral infarction, and congestive heart failure.
Okay.
And the contraindications will be severe bradycardia or high block or cardiac shock or left ventricular offender, and relative will be prismatus angina and will be bronchospasm, severe asthma, and psychiatry will be no use of propranolol in case of severe depression.
Right. Okay. Thank you. Dr. Merchant, now drug of choice in the following clinical conditions. This is the rapid fire, this thing. Diabetes mellitus.
The drug of choice will be either ACE inhibitor or ARB. We prefer to give ARB.
Heart failure with a poor ejection fraction.
The latest drug will be the combination of the valsartan with sacubitril and what is known as Vimada, which gives a fantastic.
Right. Recent MI.
Now, recent myocardial infarction, the drug of choice again will be the ARB, will be the good drug of choice, but the beta blocker we have to give later, not the recent myocardial infarct.
Okay. Bronchial asthma?
Bronchial asthma, either you give calcium channel blocker or you can give ARB.
CKD? Chronic
CKD,
kidney disease.
Yeah, chronic kidney disease. You see, ideally, I prefer to give cilnidipine. But you see, the thing is that depending on, suppose if the creatinine is 2, and you tell the patient, I will start the drug, and if the potassium is normal, and if I give the ARB, the creatinine rises, but if it rises more than 30%, then I have to discontinue. So we have to prepare the patient, and sometimes the patient, they unnecessarily blame the GPs. अरे इसने हमको गोली दे दिया हमारा और किडनी खराब हो गया
बढ़ गया
to be on the safe side I think cilnidipine is a drug of choice to be given but yes you can give ARB but then you have to keep a watch on the creatinine level and the potassium
and also diuretics
diuretic yes if there is a waterlogging edema or is a drug of choice we should give diuretic loop diuretic is a drug of choice
loop diuretic peripheral vascular disease
again the drug of choice is the calcium channel blocker and beta blocker is contraindicated.
Okay, then isolated systolic hypertension.
Isolated systolic hypertension, the drug of choice is calcium channel blocker or diuretic, or you can give both if you depending upon the BP control.
Acute stroke.
Acute stroke, I think all GP should remember that even if the BP is 150, 100, don't give any antihypertensive. But suppose if the BP is 200 and above and the diastolic is 120, then yes, we can give a small dose of the amlodipine or you can give the ARB. But you have to keep a watch on the blood pressure. But don't reduce the blood pressure very fast. You can give a small dose. You can start with 2.55 milligram of amlodipine or 20 milligram of telmisartan and then keep a watch. But don't try to precipitate the low BP and then create more problem because there is an auto-regulation going on in the brain. So the drug, if it is 150, 100, don't give any antihypertensive. If the BP is 200 and above, yes, you can give BP drug and that is either amlodipine or the ARB in a small dose and keep a watch on the BP.
Right. There shouldn't be a precipitous fall.
Correct.
Yeah.
I think diuretic also is one of the drug of choice in stroke with hypertension. Diuretic.
Yeah, you can give, sir. I agree. But if the BP reading is more than 200, yes. Otherwise, no.
We are still, just a moment, erectile dysfunction, we are still with Dr. Merchant.
Drug of choice. Now, erectile function, the drug of choice will be either ACE inhibitor or ARB. You can give calcium channel blocker, but then calcium channel blocker causes difficulty in ejaculation. But this you can give, it doesn't do any harm in the erectile dysfunction. So you can give the drug of choice will be ARB, ACE inhibitor or calcium channel blocker, but avoid beta blocker, avoid diuretic because they can give more problem with erectile dysfunction.
Also, ma'am, I'd like to add very rightly when sir said that sometimes the patients will blame you for the elevated spike in the creat. It is important to explain to them that we'll be checking it at 15 days and then again at 1 month or 3 months. Because after the initial, many a times it shows the beneficial effect and it does settle down.
Yes.
So if the fall in EGFR is less than 20% and the rise in creat is less than 30%, then you can safely continue because it will have a nephroprotective effect in the long term.
Yeah,
True. Thank you. Okay, Preeti, what is pregnancy-induced hypertension, PIH, and the drug of choice?
So, hypertension in a pregnant lady occurring in the second half of pregnancy when she had no hypertension initially is pregnancy-induced hypertension. And the drug of choice at present would be labetalol.
Okay. And what advice will be giving the patient to prevent, because after the delivery, the hypertension will settle down. But what advice should we give the patient to prevent the development of hypertension in later life?
Yeah, so she should know that she is a candidate for developing hypertension in later life if she's not careful. So she should remain on salt-restricted diet, keep her weight in check, follow healthy lifestyle, avoid junk foods, of course, and regular exercise, not sedentary habits. That would be yes.
Okay, thank you. Next, Janak. Yeah. So, Dr. Vivek.
Yes.
No. Sorry. I'm so sorry. This question is for Dr. Sarang. Dr. Sarang.
Yes, ma'am.
What is resistant? No, 16. Janak, let us go back. Yeah. What is resistant hypertension and its treatment? Sarang?
So resistant hypertension, if the patient is already taking more than 3 antihypertensive medicines along with diuretics, and if still the blood pressure is not controlled, that means it is above 140/90, then we call it as a resistant hypertension. And to evaluate it, we should also undergo renal profile of the patient. We should check renal profile. Also, we should ask for the history of obstructive sleep apnea. Along with, we should also check the thyroid of the patient. And first important is we should look for the compliance of the medicines with the patients.
Very true. Yeah.
This is how we can treat the antihypertensive. So also, we can use alpha antagonist along with other medicines if required.
Okay. 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 Thank you. Next, please, Janak. Yeah. Dr. Merchant, what is target organ damage?
Now, target organ damage is caused by hypertension right from the head to the toe. So the head means first is the brain. Brain, it can cause stroke, it can cause the dementia. Then it comes to the eye, it can cause retinopathy. Then comes to the heart, it can cause left ventricular hypertrophy, myocardal infarct, ischemia. Then you come to the kidney and it can cause kidney damage. The hypertension itself can cause kidney damage, giving rise to high creatinine, what is known as nephrosclerosis. And then, of course, these are the target organ damage which usually happen in the emergency hypertension.
Okay. Thank you, sir.
Now we differentiate the target organ damage in emergency and urgency. There is no target.
So hold on.
Yeah.
So okay. Okay. Janak, next.
Yeah.
What is hypertensive urgency and hypertensive emergency? This question is to Preeti.
Yeah. So if the blood pressure goes above 221 systolic and 120 diastolic, we called it a hypertensive urgency. But at the same time, if there is an impending target organ damage, maybe an MI, maybe renal failure, maybe retinopathy, then we call it hypertensive emergency.
Okay. Okay. Thank you, Preeti. Next, Dr. Acharya, what is pulse pressure, its normal value, and its clinical significance?
The pulse pressure is the difference between systolic pressure and diastolic pressure. Usually, it varies from 40 to 60. Now, the most important significance is pulse is very high. It shows there is some damage in the aortic wall causing regurgitation. That is the most important thing. There is something like a narrow pulse pressure also, that is also significance. But usually we talk of wide pulse pressure, that is more than 60 and above. The most important is atherosclerosis of the aortic wall, or there will be clinical, aortic regurgitation. These two conditions were to take into consideration.
Not only of the valve, but also of the, mostly this pulse pressure, high pulse pressure is seen in elderlies, and the commonest cause is atherosclerosis, generalized atherosclerosis. Am I right, Dr. Mehta?
Aortic regurgitation is one of the biggest factors because, the heart tries to push the blood at a higher rate, so the systolic goes up and a lot of it falls back in the column. So anytime, I would say very simply, rather than complicating it, if there is a wide pulse pressure, let us auscultate the patient and find out what is the grade of aortic regurgitation or stenosis. Because if you are looking at a mitral part, then we are out on a lot of problems which the patient might be facing.
But this is a common finding in elderly patients.
Absolutely common, and 40 no longer is 40 accepted as normal pulse pressure for those above 60. I think 50 or 60 is what clinically we can sustain. I'm not making a statement here. I'm just saying that clinically with our geriatric patients, a pulse pressure of 50 or 60 is usually all right. They don't do that badly.
Sometimes the severe iron deficiency anemia can cause, or even hyperthyroidism and atherosclerosis. There are three things which can cause a wide blood pressure.
Especially anemia, sir. Absolutely, and anemia is undertreated, underdiagnosed, 100%. Sir.
Okay, sir. Thank you. Next, sir, Janak. Janak, So, Dr. Sarang, this is for you.
Yes.
What is the role of ambulatory BP monitoring in diagnosis and management of hypertension?
So ambulatory blood pressure monitoring is usually done for various reasons. For example, if the patient comes in the OPD and found to have a high blood pressure. But so we need to detect whether it is white coat hypertension or no. That is number one. Second thing is we also used is to recognize the early morning surge as well as whether nocturnal dip is present or absent. Along with also it can be useful in diabetic patients to detect autonomic dysfunction and its effects on blood pressure. So in the way, ambulatory blood pressure monitoring can be used in various ways to help the treatment of hypertension.
Yeah, it's very important. If the patient does it annually, it is very important to help the maintain the BP with the medicines. We can increase or decrease the dose depending upon the nocturnal dip and the early morning surge. Yeah,
yes, ma'am.
Yeah. Thank you.
It also, I think also it gets differentiated from office blood pressure and mass blood pressure.
Yes, that Sarang said. Yeah, white coat. Yeah, white coat. So
White
it
coat,
is. You can diagnose also. It helps in the diagnosis also. First time presentation. Okay. Now, Dr. Vivek.
Yes.
This is for you. Indication for the use. Indication for the use of centrally acting antihypertensive drugs like clonidine, moxonidine, dose and side effects. Centrally acting.
Yes, this is clonidine is directly centrally acting on the brain, and it reduces the sympathetic flow, and that way it reduces the blood pressure. But as it got a lot of side effects, moxonidine and clonidine, it is very lessly they are used.
Yeah.
And the dose for clonidine is 0.1 and 0.2 in tablet form, and moxonidine is 0.2 to 0.3 milligrams is available. But these have got a lot of side effects, hallucination, dizziness. So that is why they are used very less.
Drowsiness, drowsiness, dryness of mouth.
Dryness of the mouth.
Yeah.
That is very common.
So these are one of the last drugs to be used these days.
Also, I'd like to add that with clonidine, moxonidine, we also find clonidine we used to earlier try to give for those who were coming with insomnia and hypertension. Because it used to give that drowsy effect.
Drowsiness.
Anti-anxiety is not working. But the problem is giddiness is now being linked to postural hypotension also, and with increased link to falls. Which is why it's a scary drug, and we leave it to the those cases which are not responding to our other lines. But on the other hand, I must say that these sympatholytics, they are powerful drugs. They work well. Their peripheral dilation capacity is phenomenal. They are actually very potent drugs.
Yeah. And they also call rebound hypertension. So they have to be withdrawn very gradually. You can't just stop them.
Yes.
Yes, Jana, next.
Yeah.
So this is for Dr. Acharya. How do we diagnose postural hypertension and how to avoid it?
This postural hypertension usually due to change in the position when the person moves from more vertical position, from sitting to standing or lying down to sitting. And if the difference between the systolic pressure is more than 20 and diastolic 10, then we say it as postural hypertension within 2 to 5 minutes of the checking and the symptoms.
How to avoid it?
Now, do we have to find the cause, whether dehydration, aging is one cause, some medicines they also cause. Interacting as doxycycline, terazocine, these medicines we have avoided. And patients is asked by changing the position, not so quickly, take care by changing the position.
Yes. It is also very common with calcium channel blockers. It's also very common in elderly. So, calcium channel diuretics, we have to be careful in the elderly because they are more likely to, because of impaired autonomic regulation.
And apart from that, sometimes it is merely because of calf weakness, because the peripheral pump is not working. So something which we do is at a very early stage. Suppose a 62-year-old diabetic is started on ARB, we request them to start calf exercises as an essential part for the future. Things are very uncomfortable. Hardly 5% of your patients will wear. And most important I want to put across is, I've seen it in my own patients also, anybody with any one incident also postural hypertension, humbly request them to go in the night and pass urine in sitting position only. Not to pass urine while standing at all, and keep a handle next to the pot where they can hold and they can stand up.
Grab bars in the bathroom. Calf exercises is a very good, very good point. Now this is for Dr. Saran. Significance of ophthalmoscopy in hypertension. Saran?
So ophthalmoscopy can be very important to diagnose the hypertensive retinopathy. Also, it can diagnose the optic disc edema and whether we can evaluate whether end organ damage is there or no.
Yeah.
So it can be beneficial in the treatment of hypertension to be treated at home or admission required and further evaluation. So this
and
can,
all
this
of us,
yes,
not in
this
COVID times, but all of us should learn it and do it in our clinics. Okay.
Yes, yes.
Thank you, Saran. Yeah, next slide, Janak. Yeah, this is for Dr. Merchant. No, previous slide. Yeah, so this is for Dr. Merchant. Indications for the use of alpha blockers, prazosin, terazosin, initial dose and advice to the patient. Dr. Merchant?
Now, alpha blockers are very good drugs. We have to use it in the resistant hypertension. When we have used so many drugs and not responding, we have to add on. So add on prazosin. The drug is available in 1 milligram, 2 milligram, milligram. But start with small dose. Otherwise, you may create a first dose syncope can occur. So you have to give them at night, but not in the daytime. So give them at night so they can sleep, but they have to be careful when they get up. So it can cause the first dose syncope or postural hypertension. Same thing with terazosin. The dose is again start with 0.5, 1 milligram, 2 milligram. And you can adjust the dose according to the blood pressure.
And many a times these patients don't share with us that they're already taking something for the prostate.
That's right.
Yes. So we have to find out.
एक लहान सी गोली घेतो रात्री में लकवीसाठी. And suddenly they come with a
Yeah. Thank you, Dr. Mehta. That's a very good point. Okay. So Janak, now we will share the cases and then we will go to the take-home message slides.
Okay.
So now we will share some cases and the panelists will answer. It's nice to be a moderator. Yeah. No, we can't.
Okay. Then I have to. Okay. Now?
No, Janak, not yet.
आ गया अभी already आ गया.
Not on the screen. It is not come here.
No.
Acha. Maybe we'll wait. We'll wait for some time. Okay. Till the cases come, Dr. Mehta can give us some more.
I think there are 2-3 questions.
Yeah. Let us see.
I think one of the things which is there, that what is the ideal first line hypertensive, Cochrane study on June 1st, 2020 released a paper that's diuretic to be the most widely used and the most recommended first line drug. Diuretic. So definitely we have to individualize. But
yes.
Can diuretic for me are neck and neck.
Okay.
Now it is shared?
Yes. Yeah, it is there. Yeah. Okay. So this is a case of a 56. Now this case, Dr. Merchant will comment on. This is a 56-year-old male patient. He comes into your office for a follow-up secondary to a single blood pressure reading of 148/96.
Yes.
He is obese, a chronic smoker, and occasional alcoholic. He has a family history of diabetes and premature CVD, cardiovascular disease.
Yes.
So 56 male.
56 male and obese. Now the first thing is he's a smoker. Now the first advice I will tell him to stop smoking. That is very important because smoking itself can cause hypertension.
Sir, please wait, sir.
Yeah.
At this visit, the BP, this is the second visit. And on the second visit, the BP is 150/98, 152/96, 150/95. So the average is 150/90 plus, 94.
Absolutely. Yeah. So
and all the lab reports are normal. Now you please tell what is your treatment of choice.
You mean to say his blood sugar is normal and renal profile is normal, am I right?
Yes.
Okay, but he's overweight. So he has to change his lifestyle. He has to, take small meals, avoid the oil, butter, cheese. He has to stop cooking. And now we have to start the medicine because you had said that three times the reading is taken and his blood pressure is always on the higher side.
Yes.
So I would prefer to give him, since he's overweight, and as Dr. Mehta said, the first line of drug will be diuretic, but my drug of choice is always in my practice is ARB. I would like to give the ARB, and that is telmisartan. And I will give 40 milligram once a day and call him for the follow-up. But his weight has to be reduced. So his diet, we have to tell him that he has to avoid pickle, papad, wafers, gatia, all salted thing he has to avoid. He has to walk every day half an hour to 45 minutes. And I have to see his abdominal girth. So we have to teach him that if you don't reduce your weight, you are going to be in trouble. And he has to stop smoking for lifelong. He can't smoke because the smoking itself will cause the blood pressure rising. So once he stops smoking, change of lifestyle and giving a drug and check his blood pressure, and I'm sure he will come around.
Okay. And here after 3 weeks, we would also like to repeat his potassium.
Yes, of course. Definitely.
And serum creat.
Yeah, of course.
And we'll tell him that if he can reduce his weight by 10% of the present weight, if suppose he weighs 80 kilos. So reducing by 8 kgs in the coming 6 months will go a long way. Yeah.
Definitely. I always tell my patient to reduce 1 kilo a month, so they are happy. By the 1 kilo week mein nahi bol rahe. What about the thyroid test has been done? TSH has been done?
Yeah, all this thing is normal. Thyroid is normal.
The lipid profile also has been done?
Everything is normal.
Yeah, okay, fine.
Yeah. Thank you, Dr. Merchant.
Yeah,
next, Jana, next please. Now, this case is for Dr. Preeti. A 36-year-old female recently returned to work 10 weeks after the birth of her first child. She has come back 10 weeks after the birth of her first child. She has a family history of diabetes and no history of smoking. Her vitals, heart rate 88, regular. BP is 158 by 92, 158, 94, and 160, 92. BMI is normal. On investigation, her total cholesterol is normal, HDL is good, LDL is not bad, 120, serum creat good, serum sodium, potassium, blood sugar, we don't know whether it is fasting, but random, it's good, thyroid is good, ECG is normal. Preeti?
So my first question is, did she have gestational blood pressure?
She did not
have PIH because she just delivered?
She didn't have PIH. There's no history of PIH. Yeah.
Can we go back to the first slide? Because I want to see the BP readings.
Yeah.
158, 158, 160.
Yeah.
Okay. And she has a family history of diabetes, but she is fine.
Yes. Yes.
So
her sugar is...
We will start. Yeah. Everything else is normal. BMI is borderline. Yeah. So, yes, she is not on any medication and still she has this high BP. So we will initiate drug therapy.
Yeah. But Preeti, here she might be lactating. She must be lactating.
Yes.
And then here the drug of choice would be a beta blocker. Here I would like our expert to also comment that 10 weeks post-delivery.
Why can we not give her CCBs?
Yeah, so I'm not sure
calcium channel blocker?
Yeah, we can. I'm not sure whether CCB can be given to a lactating mother.
So what we look at this is that whether she's gestational hypertension or preeclampsia, etc., whatever it is, postpartum hypertension can occur and can persist for up to 3 months. The delivery also.
Okay.
So, we keep a very close eye on her. We look at the end organ damage if it is there or not. And what is the precipitating factor. One of the non-medical interventions I will do is get her a maid because she has a 10-week child and she's handling job and everything.
Yeah, anxiety. Anxiety is
maybe 1 week of a very low dose safe anti-anxiety drug which won't cross the breast barrier. I think we can try with that. And as ma'am rightly said, any of the drugs are okay. A very low dose of beta blocker CCB should be okay. Will not interfere a lot in terms of lactation also.
Okay.
But definitely I will go for plan B. I would like to initiate drug therapy, but supportive drug therapy. Create a eustasis for 10 days first, correct the vitamins, correct anemia because she just delivered. Basically, I will go for eustasis, antihypertensive intervention, and then
and rule out end organ damage, and then accordingly we can go really slow.
Touch her feet and look deep into her eyes. That is what
okay, you do that also. Okay, next case please. Thank you, Dr. Mehta. Yeah, So this is for Sarang. A 55-year-old male comes for follow-up after executive physical checkup. Past history, BP is 157/95. Smoker, no known coronary artery. Past history of blood pressure, 157/95, non-smoker, no known coronary artery disease. Initial therapy, diet modification, increased exercise, started on 25 milligram of hydrochlorothiazide. On examination, ECG is normal. Pulse is on the lower side, 67. Urine is normal. Total cholesterol is high. We don't have the breakup, HDL, LDL. Fasting is high, 140. And glycosylated is 8.2. Next slide, please. That means he's a diabetic. Sarang, 55 male.
Yes.
Yeah. High pressure and first time maybe detected diabetes. Heart sound normal. Nil to suggest secondary cause of hypertension. Fundoscopy, no changes. Blood pressure, 158/96. 158/95. 160/92. Left arm similar. Next slide, please. What will you recommend, Janak? Here, you want to go back to the first slide?
No, I don't want to go back to first slide.
Yeah. So,
what would you do?
After executive health checkup, he has been detected with high pressure and diabetes.
So as per the first slide, he has already been given the lifestyle modification and also
a diuretic. And a diuretic. Which was in a very high dose. 25 milligram is a very high dose of hydrochlorothiazide. Yeah.
Yes. So as per the JNCAT guidelines, I would also like to add another new drug with plan B in a small dose. So I think that will be the, I would, plan B will be the ideal, I think.
Yeah. And also a anti-diabetic, oral anti-diabetic.
Yes, and to treat the
but
diabetes.
why not cut down the HCT?
That should be cut down to half.
No, madam, we'll stop this hydrochlorothiazide because it will cause dysglycemia plus
glycemia.
Okay.
So first time you stop hydrochlorothiazide. And
yes, sir. Yes, sir.
Add a ARB, start a ARB.
Yes, start with ARBs.
With metformin.
Yes, metformin. Let him do lifestyle modifications.
Lifestyle modification.
And the BP. Then you add calcium channel block rather than adding the hydrochlorothiazide.
Very true.
Again, this gentleman is a prime candidate for an SGLT2. If he requires diuresis, let's give him an SGLT2. So sugar and diuresis both is taken care of. At the same time, we can start an ARB, and because his pulse is good, he's a prime candidate for a good low-cost calcium channel blocker also.
Right.
And also the lipid lowering therapy if required.
Yes, lipid as such, because he's a diabetic. Anyway, we will give him a statin because diabetes itself is a risk factor for ischemic heart disease.
Yeah, but ma'am, I think we'll first resolve his glycemia and then look at the dyslipidemia. What is the remnant dyslipidemia? Because they say that first resolution of fasting sugar will give us a better hepatic output in terms of the lipid profile also.
Okay. But diabetes itself is all diabetics should be. Yeah.
Absolutely, yes, it's a blanket indication.
Yeah.
So that will resolve the triglycerides if they are there. No, not the total cholesterol. So what we are worried is triglycerides will be taken care of if the sugar comes down.
Yes.
But total should be treated.
Definitely, it has to be blanket.
Now,
the dosage is what I'm saying. Instead of just starting at high dose, once we start in the kick in, then we can up titrate rather than down titrate retrospectively in a stable pit.
Agreed. Okay. Janak, now can we go to the take home messages slides? Yeah.
Okay. Okay. So last slide you want?
Yeah. No, there are 5-6 slides on THM.
Yeah. 1 second. Just go for. So here it is.
We'll have to wait. We have not got yet.
You have got it now, I think.
I don't. Others
You
have
got
got
it?
it.
You have to
I have
double
not.
click. You have to double click, boss. Double click to enter the full screen mode. Double click.
I've already done, boss.
Okay.
No, it's not come.
Janak, if you have got it, you can start reading the take-home messages, starting from when
Now
do
you
we?
got it?
No,
Nahin.
not
Now
yet.
you got it?
No.
Okay, then wait. Just give me time.
Avanu છે.
આવવાનું છે તો જોઈએ. Just give me 2 minutes.
Okay. Dr. Manan can give us some polls again, wisdom polls.
No. I think that it is very wrongly labeled as expert. I think I'm the student of the panel, and I hope that they are not angry with me and upset with me, and they will allow me to be their student forever.
That we will discuss later. First, to talk about your experiences.
Now it is there?
Yeah.
So one of my masters, Dr. Jagdish Shah, is a practitioner since many years, and I have seen almost every case under the sun under him. What he has taught me is that never underestimate the value of counseling and an anti-anxiety. A low dose anti-anxiety goes a long way in solving secondary hypertension. Don't look at secondary hypertension only as renal artery stenosis and pheochromocytoma. Look at it as mind attack also.
Right.
So that causing less sleep, causing increased anxiety, causing acidity, causing prescription cascade. Everything has to be looked at, and a low dose anti-anxiety and counseling goes a very long way in managing most hypertension cases.
Yes. And also walk and exercise, because that
Sir,
causes
which anxiety drug would you like to give?
Usually all the psychiatrists are less angry if we prescribe clonazepam and send it to them. Otherwise they call me up and tell me, "Aapko pata hai kya iska kya hota hai?" So
I
usually maybe a clonazepam, safest one, centrally acting, not known to have any pulmonary effects, easy to wean off also. And in an elderly patient, maybe a short acting one like zolpidem. Start with 5 milligram and then maybe go higher.
Yes. Yeah. Very true.
Actually, I always ask the patient, what time would you like to wake up before I give them the timing for the dose? Because otherwise, clinically, that drowsiness or the that is not going to work. So there is always that learning phase which is there for.
Yeah, that is true. So,
Think you got it?
no, I think. Never mind. We'll read it from our mail.
Yeah.
Sunita, before we begin,
yes,
I just want you all to join me in congratulating our Dr. Waza.
Yes, absolutely. Absolutely.
Corona warrior by His Excellency Governor at Raj Bhavan. And he had this one goal, he wanted to collect 1,000 bottles per day for 10 days of Ganpati festival at Lal Bagh Cha Raja.
Yes,
and he collected 10,100 bottles.
Yes, sir.
So let's clap for him, like big cheers for him.
Cheers.
And
yes, sir.
Rather than calling a Lal Bagh Cha Raja, I'll call him Lal Bottle Cha Raja. Okay.
That's right. Absolutely.
Very apt. Very apt.
બે મતલબ થયા એનો ભરતભાઈ.
Very apt.
आप confirm बताना चाहिए बाकी I call him blood sucker only.
Very apt. I also call him as the pride of GPA. Pride of GPA. He and Dr. Rajni.
Absolutely.
I'm not able to get my. So, Dr. Merchant, can you just say the take-home messages?
Yes, take-home message. I think I can give. There's no problem. Let me tell you, the hypertension is a silent killer.
Yes.
And it should not be neglected. We have to, tell the patient that treatment is going to be lifelong. They have to be on compliant.
Doctor साहब बहुत echo हो रहा है.
Echo हो रहा है मेरा?
बहुत echo हो रहा है. We have to shut down other devices maybe.
Yeah, mute everybody, and let my thing will be on.
Yeah.
So, I think
I will mute myself. Yeah.
So the person should have a change of lifestyle. Walk every day, half an hour to 45 minutes a day. that they have to do. They have to take care of your
આવે છે ને
diet.
બોર્ડ ઉપર આવે છે ને
They have to avoid pickle, papad, wafers, gatiyas. You know, they 2.5 gram of salt, 1 gram of salt, they can't digest. So what we have to tell them,
I'm
that,
just
Mama, avoid
going out of
pickle,
stop
papad,
sharing
wafers, gatiyas. So then they
તો
are
stop
happy.
share કરું છું
And don't take any salted lassi and all. So the change of lifestyle is very important. Walk every day. See that they smile and they laugh. And Albert Pinto should be out. That is very important. And if you change the lifestyle and taking the medicine properly, and I'm sure we can control their blood pressure, we can prevent the disaster in future, because the hypertension is a killer. It can cause right from the stroke to heart failure to myocardial infarct to various other problems. So we can avoid the problem, but we have to advise the patient to change the lifestyle, walk every day, diet restriction should be there, and they should stop smoking. No tobacco in any form, whether it is hookah or it is cigarette or it is bidi. They have to stop. And I tell them to take the vow. They have to take the kasam. So if they are married, they are ready to take the kasam of their wife. I said no, nothing doing. They have to swear by their children or the mother. So they have to take that, and the alcohol should be restricted. They can't drink alcohol. Yeah, the slide has come. No, no. So this is my take-home message, that change of lifestyle, avoid tobacco, be happy. Don't get bogged up in all these news going on. Be happy. And it's not easy to get people get so much tense with that. And if they learn to relax, do little yoga, and the yoga helps. And of course, if they are meditating, whether any religion, whether it is Muslim, they have to pray namaz. If it is Hindu, you can do puja, whatever you want to do. And one asana in the yoga is called savasana.
Yeah.
It helps to reduce the blood pressure. So that is the take-home message. They should do it. And of course, we have told all the drug side effect. That is take-home message. That what is calcium channel gives rise to what side effect. What is beta blocker? What side effect it can occur, and when not to give, when to give. And I think Dr. Sunita Mangli has taken a wonderful job of moderating.
Sir, 1 minute. Sir, 1 minute. Sir, 1 minute. Also, regarding the levels of blood pressure, if the age of the patient is less than 65 years and the patient is a diabetic, then our level should be, our goal should be 130/80.
Absolutely agree, madam. Absolutely agree.
But without diabetes, less than 65, we can very well keep the pressure at 140/90.
Absolutely. And I think all the geriatric patients, we should take the blood pressure standing and see that there is no fall of blood pressure.
Absolutely.
And even if they are 140/90, 150/90, don't try to reduce the blood pressure. Otherwise, they invariably complain of dizziness and have a fall. We don't want to have fracture.
Yeah.
So I think in the old people, we should be little generous. Give 140/90, 150/90, no problem.
150, yeah. So more than 65, we can very well, we don't have to treat the pressure at 150/90. And for diabetics, we can keep it little lower, 140/90. But yes, you rightly said, more generous.
And we have to tell them, husband gets the blood pressure. Whenever the couple comes to my clinic, and the wife tells me, come and check my blood pressure, and I tell them the ladies by and large don't get blood pressure, they give it to others. This is just a joke. But I think if the wife becomes loving and sympathetic and kind to their husband, I'm sure that blood pressure can become normal, and they may not require even medicine.
No, that is mutual. That is, mutual.
Okay.
I would like to add one sentence. You see, these are known as international guidelines.
Yeah.
But take them as international guidelines. That is the only thing. Okay, so that has to be a take-home message also.
Okay. So now I will invite Dr. Waza, the pride of GPA, to give a vote of thanks.
Thank you, madam. Am I audible?
Yeah.
Janak bhai.
Yeah, you're audible.
I'm audible.
Yeah.
First of all, let me thank our president and you all for appreciating my whatever little I have given to the society. And it is not. It's a collective efforts by all of us. So I thank you all for appreciating me. This is our first webinar after the post-COVID era, And let me put it that it is a grand success for the day. I think we would not even enjoyed our routine CME. It was such a fantastic. And our distinguished esteemed speaker, Dr. Manan and Dr. Jinam, they they talked, they gave the insight of the subject in a very simple, conducive, in a very thoughtful manner. And they require a big round of applause because it was they give us the real take-home message on the respective subject. And I think everybody must have enjoyed. It was a pleasure and experience to listen to Dr. Manan, Dr. Jinam. They're really inspiring, and that every word is, like a take-home message.
Yes.
So it was a fantastic. I thank on behalf of General Practitioner Association, Dr. Manan, Dr. Jinam, for an excellent, wonderful talk given by them. How can then our third talk was पैनल डिस्कशन मैडम सुनीता मैडम आपके लिए तो क्या बात कहूँ मैडम यू आर सो फैंटास्टिक यू आर अ वर्सेटाइल नॉलेजेबल you are such a versatile knowledgeable personality with a real insight of the subject. You are no less than any speaker, madam. It was a pleasure to listen to you throughout. I thought at one point you only continue and don't let others panelists to speak. It was such a fantastic.
Thank you, sir.
And
thank you.
Our all panelists, including Dr. Mehmood Merchant, Dr. Preeti Madam, Dr. Vivek, Dr. Acharya, Dr. Sarang, they individually, their years of expertise, their years of experience, they spelled out in just a few minutes. And they are no less than any teacher. I would put it like that, Dr. Especially Dr. Mehmood Merchant, sir, Doctor. It is a really pleasure to listen to Dr. Mehmood Merchant, sir, Dr. Preeti Madam, Dr. Vivek, Dr. Sarang, and Dr. Acharya. It was a fantastic journey, madam. And the driver was Sunita, madam. When you are a driver, I think no journey becomes every journey becomes a fantastic.
And Janak was the
and I will be failing in my duty if I don't recognize the efforts put by our giant man and his giant work. Is a Dr. Janak Shah. He has done it so wonderful. I think he must not have slept yesterday night. Because since morning I've been seeing him that he's connecting. He's trying to contact and connect each and every GPA member, and to check whether the show must go successfully. And he has put it his all efforts, and by the grace of God and with all his kind effort, I think our this journey of first webinar after post-COVID has become a grand success. On this occasion, once again I thank our all esteemed speakers, our president Dr. Bharat Bhatt, our Madam Sunita Manglik madam, and our special expert is Dr. Manan. He requires a double round of applaud because one is a speaker, one is a expert, and his experts comments were even more very catchy. Little tips, but it carries a lot of meaning. Dr. Manan sir, really we would like to listen to you again. Dr. Jinam Shah, we would like to listen to you again and again. So please remain with GPA forever, and we need your constant blessings. And madam, once again I thank you, and I thank all our panelists. And it's a grand success. So let us clap for all of us and for GPA. Thank you, madam.
Thank you, sir.
Thank you.
Thank you. Bye.
Thank you.
Thank you, everyone.
Thank you, sir. Thank you, Janak. Thank you, everybody. Preeti, Dr. Merchant,
Thank
Dr.
you,
Acharya.
Sanita. Yes,
Thank you. Thank you, Mehta, Dr. Manan Mehta.
Actually, exactly.
Thank you, Vaza, sir.
Thank you, Vaza.
Thank you, madam.
I
Thank
think
you, madam.
only we overvoted 10 minutes.
Cross
10 minutes more.
Yeah.
Okay.
Yeah.
That's fine. I think we were within the time limit.
Yeah.
But
instead of starting late, 15 minutes.
Thank you.
Contents are worth.
Yeah. Chalo, thank you, everyone.
Thank you. Thank you.
Thank you, Janak. Thank you for being there.
Wonderful. Thank you.
Thank you, sir.
Janak. Bye.